3, 2, 1. Please start. We are live.
Hello, good evening, everyone. And it's with great pleasure that we welcome you all for the day 2 of Updates in GI Oncology, a very thought-provoking and well-knit program by none other than our conveners, Dr. Srinivas KG. Good evening, sir, to you. Everyone knows Dr. Srinivas. He is a consultant medical oncologist at Bharat Hospital and Institute of Oncology, Mysore. We have a fantastic scientific committee with Abhay Kumar sir, Dr. Naveen on board, and Dr. Raghunandan. So without wasting any more time, it's once again a pleasure to welcome you all. A great good evening. We hand over the mic to Dr. Srinivas for his opening remarks and take the things forward. Over to you, Dr. Srinivas, for today's webinar, please.
Thanks, Tarun and team, for the opportunity and for warm introduction. Today being day 2 event for updates in GI oncology, we have gastric and colorectal malignancies in the event. Today we have a wonderful speaker, Dr. Dan Edreka, professor and head in GI services Israel. He has vast experience and he's going to talk in the middle of the event. We look forward for a great talk by him. And without much ado, I would like to welcome Dr. Naveen Jairam Anvekar. He's a senior consultant medical oncologist at Narayana Hospital, Mysuru, to talk on nivolumab plus chemotherapy or ipilimumab versus chemotherapy as first-line treatment for advanced esophageal squamous cell carcinoma. Dr. Naveen?
Yeah. Thank you, Srinivas.
Over to you, Dr. Naveen.
Yeah, thank you, Srinivas, for the introduction. Can I share my screen? Yeah, is it visible?
Yes, sir. Make it full screen, sir.
Okay.
Yes, now it's visible.
Yeah. I'll be speaking on a trial Checkmate 648, the role of nivolumab plus chemotherapy or nivolumab with ipilimumab versus chemotherapy as a first-line treatment for advanced esophageal squamous cell carcinoma. And we have come across this one previous results, but here I will be speaking on the 29-month follow-up of the trial. As we know, this one esophageal cancer is the 6th leading cause of cancer-related death globally, and esophageal squamous cell carcinoma approximately 10% of all. The standard chemotherapy regimen result in fully recommended this one treatment for the first the drug combination of nivolumab and chemotherapy and nivolumab with ipilimumab demonstrated a superior overall survival versus chemotherapy and acceptable safety profile in the previous untreated patients with advanced esophageal squamous cell carcinoma as per the Checkmate 648 trial. And based on these results, nivolumab with chemotherapy and Nivo-EP are now approved in the US, European Union, Japan, and other countries as a new standard first-line treatment for patients with advanced esophageal squamous cell carcinoma. And I'll be talking about the longer follow-up of this study. And this study design was a randomized phase 3 trial where the key eligibility criteria was unresected advanced recurrent or metastatic esophageal squamous cell carcinoma with ECOG PS of 0 to 1 and no prior any treatment for advanced disease, and it should be a measurable disease. And patient was stratified based on PD-L1 expression, the TPS score of less than 1 or equal or more than 1. And the region based on this one East Asia, rest of Asia, or rest of the world, and based on ECOG PS and the number of organs involved. And the study involved around 900 to 1,000 patients, and they were randomized 1:1:1. And this one first arm contained nivolumab every 2 weekly with chemotherapy, which included 5-FU cisplatin every 4th weekly. The second arm comprised nivolumab every 2 weekly and this one ipilimumab every 6th weekly. And the third arm comprised of only chemotherapy arm, which was given every 4th weekly. And the primary endpoint was overall survival and and PFS in patients with TPS PDL score of more than or equal to 1. The secondary endpoint was overall survival and PFS in all randomized patients, and also the overall response rate in patients with TPS score of more than 1 and in all randomized patients. And the baseline characteristics were balanced across all treatment arms and were consistent with those patients with TPS score of equal or more than 1. And around 50% of patients were having a score of more than 1 or equal to 1. And most of the patients who were included in the study were de novo metastatic cases, and there were less what are called recurrent locoregional patients. And around 50% of patients had had one set of metastasis, and around 50% of the patients had more than 2 sets of this one organ involvement. And coming to the median duration of treatment, the patient with nivolumab and chemotherapy received the treatment of around 5.7 months versus 2.8 months and 3.4 months. And in all the group, the major cause for discontinuation of the treatment was disease progression, around 55 to 61%. And 59% of all randomized patients received subsequent this one treatment, and predominant subset treated across all 3 treatment arms was chemotherapy, and subsequent immunotherapy was received by 9%, 6%, and 18% in all the 3 arms respectively. And coming to the median overall survival, the median overall survival in patient with TPS score of more than 1 in the group of Nivo and chemotherapy. I'll be speaking first about Nivo chemotherapy versus chemotherapy, and later Nivo EP versus chemotherapy. In the and the median overall survival was 15 months in Nivo and chemotherapy arm versus 9.1 months in the chemotherapy arm, with a hazard ratio of 0.59. And in all randomized patients, the median overall survival was 12.8 months versus 10.7 months, with a hazard ratio of 0.78. And there was a clinically meaningful improvement in the overall survival with Nivo and chemo versus chemo in patients, both randomized patients and in patients with PDL1 score of more than 1. And tumor cell PDL1 more than 1, 40% those patients who had score of more than 1, there was a 41% reduction in the risk of death, and there was an improvement of median overall survival by 5.9 months, and there was a 33% reduction in the risk of death in all randomized patients. And this is an overall survival subgroup analysis, and across all the subgroups which you come across based on ECOG, based on the number of organs involved, and based on what are called disease entity, whether they presented de novo or recurrent cases, the overall survival across all the groups favored the Nivo chemo arm compared to the this chemotherapy arm. And most of this improvement in what are called response was seen in patient with PDL score of more than 1%. Anything about more than 1% did not make such a this one significance. Maybe this one more than 5% or more than 10%. The response was good in all the groups, and the results across baseline what are called PDL1 status subgroups were generally consistent with those previously reported, and the hazard ratios were below 1 in most PDL1 expression subgroups, favoring Nivo and chemotherapy arm. And the largest magnitude of overall survival benefit was observed in patients with score of more than 1, with no further enrichment in higher tumor this one PDL1 score. And the PFS, the median PFS in patients with TPS score of more than 1 with a Nivo chemo arm was 6.8 months versus 4.4 months, with a hazard ratio of 0.67. And in the all randomized group, the hazard ratio was 0.883. And there was a significant benefit here. And patient with PD-L1 score of more than 1, the overall response rate was around 53% compared to 20% in the chemotherapy group with higher CR and higher PR, and the duration of response was also very significant, 8.4 months versus 5.1 months in patient with TPS score of more than 1. And the duration of response was also significant, 22 months versus at 24 months, the duration of response was seen in 22% of the Nivo chemo arm versus 13% of the chemo arm. And in all randomized patient also, the overall response rate was very significant, for 47% versus 27%, and the duration of response was 3.2 months versus 7.1 months, and at 24 months, the duration of response was 21% versus 30%. And so they concluded that the overall response rate remained higher and the responses remained more durable with new chemo arm compared to chemotherapy in the longer follow. And when they compared the Nivo EP arm with chemotherapy, the overall survival rate here also was significant. The median overall survival was 13.1 months versus 9.1 months with a hazard ratio of 0.62. And in all randomized patient, it was the median overall survival was 12.7 months versus 10.7 months with a hazard ratio of 0.77. And they concluded the clinically meaningful improvement in overall survival in Nivo EP arm versus chemo arm in the tumor with PD-L score more than 1% and randomized patient was maintained with a longer follow-up. And across all the groups, the Nivo EP arm was favored compared to chemotherapy. And like in the previous subgroup analysis, the result across baseline PD-L1 status subgroups were generally consistent with those previously reported, and the hazard ratios below 1% in all PD-L expression groups favoring Nivo EP arm compared to the chemotherapy. And the largest magnitude of overall survival benefit was observed in patients with score of more than 1 with no further improvement. And the progression-free survival also was not that significant. It was around 4 months compared to 4.4 months with a hazard ratio more than 1. And the median PFS in the all randomized group was also not that impressive. It was 2.5 months versus 2.9 months versus 5.6 months with a poor hazard ratio. And there was no PFS benefit was observed in Nivo EP arm compared to the nivolumab chemotherapy arm when both were compared with the chemotherapy arm. And in patients with all randomized population and also in patients with PD-L1 score more than 1%. And but still the overall response rate was significantly higher, 35% in the Nivo EP arm compared to 20% in the chemotherapy arm. And also the median duration of response was also very good, 11.8 months versus 5.7 months with a duration of response at 24 months of 36% versus 13%. And so was with all randomized group. The overall response rate was 27% in both the group, and the median duration of response was 11.1 months versus compared to 7.1 months, and the duration of response at 24 months was 29% compared to 13% in the chemotherapy now. So the overall response rate and the duration of response remained higher in patients with PD-L1 score more than 1%, though the overall response rate was same in the all randomized group. And coming to the treatment-related adverse effect at 29-month follow-up, you can see that the safety results in all the treated patients remain consistent with those previously reported. And the most common side effects in the Nivo chemo arm was nausea, which was seen in 59%, decreased appetite and stomatitis. And in Nivo EP arm, the most common side effect was rash, followed by pleuritis and hypothyroidism. And in the chemotherapy arm, it was nausea and decreased appetite and anemia. And this one serious serious adverse effect was seen in around 20 around with grade 3 or 4 was in around 19% of patients with the Nivo chemo arm compared to 23% in the Nivo EP arm compared to the 13% in the chemotherapy arm. So as you can expect, in the most common side effect which they came across, it was the renal impairment, maybe cisplatin induced or immunogenic. And with the Nivo EPM, the most common side effect what they saw was involvement of the skin, and there were other immunogenic side effects. The incidence of tumor-related was consistent with previously reported results. The majority of the events with potentially immunologic etiology were grade 1 or 2, and grade 3 was seen in 6%, less than 6% across all the groups. To summarize, nivolumab chemotherapy and nivolumab ipilimumab continue to demonstrate clinically meaningful survival benefit and durable responses versus chemotherapy with longer follow-up in previously untreated patients with advanced esophageal squamous cell carcinoma, and the overall survival benefit with Nivo chemo and Nivo EP in patients with a TPS score of more than 1% and all randomized patients, and overall survival favored Nivo chemo and Nivo EP across most subgroups. The PFS benefit and the higher overall response rate was seen in nivolumab chemotherapy arm, and the longer duration of response with nivolumab containing regimens, and no new safety signals were identified with both this group with longer follow-up, and these results further support nivolumab with chemotherapy and nivolumab with ipilimumab as a standard first-line treatment of patients with advanced esophageal squamous cell carcinoma. Thank you. Any questions?
Thanks, Naveen. Thanks for that wonderful presentation. These are something which are welcoming because now we have a lot of options. Nivo with chemo, better responses, better duration of responses, something which we can actually also do in our centers because now nivolumab is also available for us with PAP program. I think these combinations, I think we need to do and see how our patients will do in our clinic. Thanks for that wonderful presentation. Next, we'll move up on to the second topic about neoadjuvant trial in adenocarcinoma of esophageal and GI junction cancers. Dr. Abhay Kumar is a senior consultant medical oncologist at Manipal Hospital, Bangalore. I welcome Dr. Abhay. Dr. Abhay, are you there?
Yeah, hi.
Over to you, Abhay.
So slides are visible?
Yes, sir, it's visible.
Audible?
Yes, your voice is audible.
So thank you, Srinivas, for having me here on this platform. So today I'm talking about one important abstract, which is about the NEO-AG study. That is, which is a neoadjuvant trial in adenocarcinoma of the esophagus and esophageal junction cancer interventional study. So we know about these two studies. On one side, we have a study with preoperative chemoradiation for esophageal and esophageal junctional cancer, that is both squamous and adenocarcinoma, which has shown survival benefit, that is the cross trial. On the other side, we also have studies with plain chemotherapies for perioperative chemotherapies followed by surgery in GI junction cancers. So major question is that post-cross publication, so majority were following cross trial. So whether since the patients are undergoing radical lymphadenectomy and en bloc resection, does the radiotherapy must, there is cross trial protocol, does it must? This is what has been addressed in this study. So it is quite interesting study. So we can see that patients with only adenocarcinoma are involved in this study. Either esophageal and advanced esophagogastric junction cancer, stage 1 to stage 3. C2, T2, clinically T2, T3 lesions, and N0, N3 or any node positive patients are included. 377 patients are randomized to one group have received neoadjuvant concurrent chemo radiation. So radiation dose is around 41.4 gray and weekly paclitaxel carboplatin, so followed by surgery. So other group has received neoadjuvant perioperative chemotherapy. So neoadjuvant followed by adjuvant chemotherapy with the surgery. And initially for 5 years, where the MAGIC trial was the standard, they used ECF, UOX, EOX and ECX protocol, 3 cycles before surgery, 3 cycles after surgery. But once FLOT trial became a standard of care from 2018 onwards, so around so few patients have received FLOT trial 4 cycles before and after surgery. The primary endpoint is overall survival. Secondary endpoints include disease-free survival, time to treatment failure, toxicity, tumor regression rate, R0 resection, post-operative complications, and quality of life. The key elements of this trial is that, as I told earlier, so all adenocarcinomas are included with advanced esophageal cancer stage 1 to 3, and the primary tumor length is less than or equal to 8 centimeter. T2, T3 tumors, any node positive are included. So patient underwent staging with the PET CT scan and also endoscopic ultrasound. They also defined strictly about the operative complications. So according to the esophageal complication consists group and Clavian Dindo severity score. So this is the radiation field they use, that is gross tumor volume, CTV and PTV. So if you see the demography, so the patient characteristics are well matched between the both groups, chemo and as well as CTRT group. So majority of the patients were male patient, and you can see that 85% patients have received MAGIC trial protocol, and only 15%, around 27 patients have received only FLOT protocol. So 84% patient had T3 disease, and 56% in the cross and 60% in the chemo arm are node positive. 80% in the CTRT arm underwent surgery, only 75% in the chemo arm underwent surgery. And you see the toxicity, so there's a significantly higher number of neutropenia and diarrhea in the chemo group, so compared with the CTRT group, and also numerically higher incidence of vomiting, neutropenic sepsis. But on the other side, more toxic deaths are seen in the CTRT group, but it is not significant. If you see the outcome results, so why PN0 is seen in significantly higher in the cross trial group compared with the chemo group, nearly 17% higher incidence, and around 95% in the cross trial underwent surgery compared to chemotherapy. There is also significantly very higher number able to undergo surgery in the cross trial. Similarly, so post CTRT, significantly higher number of patients achieved complete response, that is 17% in the CTRT group compared with only 5% in the chemo group, and also significantly higher major pathological response seen, that is 12% in the chemo versus 42% in the cross trial. And if you see the complications for either post chemo or post CTRT, see almost there is no significant difference between any group, but you can see that little bit numerically higher in hospital mortality we can see in the cross trial arm. So similarly, higher incidence of numerically higher incidence of ARDS we can see in the cross arm, and higher pneumonia in the chemotherapy arm. So when we analyze the 3-year overall survival data, so whether either in the perioperative chemotherapy group, it is 3-year survival is 55%, and in the cross trial arm it is 57%. There is no difference in the survival, even though there is a significant higher response seen in the cross trial, but there is no survival difference with hazard ratio is 1.03. So the summary is that perioperative chemotherapy appears not unacceptably inferior to cross regimen, that is a combination of concurrent chemo radiation with 3-year survival rate of 55% and 57%, which is not significantly different. So even though the patients in the cross trial had higher number of pathological complete response, major pathological response, and underwent maximum R0 resection and nodal downstaging because of higher P-N0, but that did not turn into the overall survival benefit. And also there is no difference in the severity of complications in the and mortality, post-operative mortality. So post radiotherapy. And in this study, there is no clear winner. So in the both chemotherapy as well as CTRT arm both are equal. So chemotherapy arm is non-inferior to cross trial arm. So the data supports clinical equipoise in decision making. So the pattern of recurrence. So even though there is a higher response rates, complete response and major pathological response rate, but that did turn out into survival benefit in the cross trial arm. So the future recurrence data may inform. So how these all we consider them as a proxies of oncological outcome in cross trial. So did not translate into the survival advantage. So based upon this trial, we can say that so the selection of patients, whether for chemoradiation or whether for chemotherapy, has to be made case-to-case basis. Thank you.
Thanks, Abhay, for that wonderful presentation. I have a few questions for you, or rather, interaction, I can say. So, in your clinic, what you are doing when you are getting a GE junction tumor, adenocarcinoma, T3N1, say something like that, with a perigastric lymph nodes in PET? What are you doing in your clinic?
So I will usually give our surgeons are only in favor of chemotherapy followed by surgery. So mostly they usually don't like CTRT. So in this situation, my plan is to give neoadjuvant chemotherapy, surgery followed by adjuvant. FLOT is the standard.
But if you see, interestingly, when you show the data, the complete pathological response, and all those were higher in cross regime, isn't it?
Yeah.
I feel like, okay, as far as the pathological response is concerned, cross regimes are good. But as you rightly said, if you have the intention of doing the surgery, a surgeon doesn't like post-CTRT situation where they feel that they end up in more morbid surgeries. Probably that is one thing what surgeons don't like about neoadjuvant CTRT, probably because surgery may be difficult for them. But see, I am also doing the same thing. My as of now, I am doing FLOT, 4 FLOT followed by surgery followed by adjuvant 4 FLOT. As you rightly said, it depends on case to case whether the patient's preference, all those things matters actually. And I think it should be individualized. And as you rightly said, there is no winner in this situation. I think both the regimes are well accepted depending on the patient's situation. Thanks for that wonderful presentation. Next, we'll move upon to the third topic, Infinity trial. It's a multi-center phase 2 trial of tremelimumab and durvalumab as neoadjuvant treatment with MSI high gastric and GE junction tumor. By Dr. P.S. Dattatreya sir. Dattatreya sir is a senior medical oncologist and my mentor. He is a senior medical oncologist in Hyderabad. Can we start?
Hello, everyone. I am here to talk about the Infinity study by the GONO investigators. This is a multi-center, single-arm, multi-cohort phase 2 trial of a double IO combination of tremelimumab, which is an anti-CTLA-4 antibody, and durvalumab as neoadjuvant treatment of patients with MSI high resectable gastric or GE junction adenocarcinomas. I think immunotherapy is here to stay and will be the future. Next slide. to take us about some background before we go on to the main trial. In resectable gastric or GE junction cancers, dMMR or MSI high status gives us better survival, but also a lack of benefit from chemotherapy. One of the strongest predictors for the efficacy of immunotherapy across almost all cancers is MMR deficiency status or MSI high status. Immunotherapy shows higher activity in early versus advanced stage dMMR or MSI high GI cancers and immune checkpoint inhibitors, as we all witnessed with the way the dostarlimab trial went viral, may allow omission of chemotherapy, radiation therapy, or even surgery. When we give a single dose of an anti-CTLA-4 antibody like tremelimumab at 300 mg and add it to durvalumab, which is an anti-PD-L1 antibody, you find higher T-cell expansion, which might translate to better responses and better survival outcomes. Next slide. We'll now come to the trial design of the Infinity trial. Now, these are patients of resectable gastric or GE junction cancers, central confirmation of the MSI high and dMMR status, EBV negative, clinical T2, T3, T4, NEN, M0. What about the treatment? Tremelimumab 300 mg on day 1 and durvalumab 1500 milligrams on day 1, on day 29 and day 57. At the end of 12 weeks, we go for a restaging with a CT and a PET, endoscopic ultrasound, multiple biopsies, including nodal FNSs if required, and most importantly, also do liquid biopsy to look at the minimal residual disease status. And then we have 2 cohorts. You operate upon these patients and then do standard follow-up. That's cohort 1. In cohort 2, you stratify the patients into those patients who get complete response and those who do not get a complete response. In those patients who get a CR after completing 12 weeks, which means 3 cycles of durvalumab and 1 cycle of tremelimumab, if it's a complete response, then only intensive follow-up is done every 12 weeks for 2 years. And the intensive follow-up is CT, chest, abdomen, pelvis, endoscopic ultrasound, multiple biopsies, nodal FNAs, and liquid biopsy to assess the ongoing MRD status. And this is done every 12 weeks for 2 years. But any point of time during this intensive follow-up, is evidence of disease or tumor regrowth, then we go on to operate. In those patients of incomplete response, we go for surgery straight away and then standard follow-up. That's for cohort 2. Next slide. We will discuss here about cohort 1. The primary endpoint here is to look at the pathological complete response after surgery, which is YPT0, YPN0, and look at the negative ctDNA status after neoadjuvant immunotherapy. A host of secondary endpoints like quality of life, DFS, OS, safety, surgical morbidity, and some translational analysis. The primary endpoint in cohort 1 is after 3 cycles of durvalumab and 1 cycle of tremelimumab, we look at surgery, and in the surgery, we look for pathological CR and also negative ctDNA status. Next slide. 18 patients were enrolled from May 2021 till February 2022, of which ultimately 15 patients were evaluated for the primary endpoint. 1 patient with PT did not undergo surgery, whereas 14 patients underwent radical surgery. So of the 15 patients, 1 patient had progressive disease and 14 patients underwent radical surgery. What about the baseline features? Median age around 71 years, 67% males, ECOG PS0, 67%. Majority of the patients, 80% are primary site gastric cancer. T2, 5% of patients, T3, 56%, T4, 39%. So of the 18 patients, 7 were T4. Almost 80% of patients were node positive, and around 4 of the 18 patients had bulky nodal disease. Next slide. Let's look at the primary endpoint. of all the evaluable 15 patients, a rate of path CR was 60%. And if you also look at those patients, rate of path CR was 60%. And if you also label major path CR as less than 10% of viable cells, then this number climbs to 80%. So 80% of patients, you have either no disease or less than 10% of viable cells. Next slide, coming to survival endpoints. There have been 2 PFS events, but the gastric cancer specific PFS is in excess of 80%. There have been 3 OS events. 2 were late postoperative complications, and 1 was second primary brain cancer. Next slide. So of the 3 OS events, 2 were late postoperative complications, and 1 was second primary brain cancer. The gastric cancer specific PFS is around 80% or in excess of 80%. What about the immune related adverse events? As you can see, the grade 3 adverse events are hardly any or less than 10% in single digits. 17% of patients had any grade hepatitis, 22% of patients had pruritus or thyroiditis. So overall, a pretty safe combination to use, and all the adverse events resolved with steroids and did not impair the surgery. The global quality of life clearly tells us that this is a treatment combination which does not impair the quality of life. Next slide. We look at the tumor mutation burden at baseline, and you found a numerical correlation to your right with PET-CR for baseline tumor mutation burden. But look at the p-value at 0.2. So only a numerical correlation is found. But as far as the clinical staging to your left is concerned, now you see that we have 6 patients who had T4 lesion. Only 1 went on to get a PET-CR. So if it's a clinically T4 lesion, then only 17% of patients go on to get a pathological complete response. This possibly tells us that T4 lesions probably should not get this treatment combo, because as a neoadjuvant combination treatment of durvalumab and tremelimumab, the PAS here is 17% only if it's a T4 lesion. On the other hand, if it's T2 and T4, then the PAS CR rate is as high as 89%. So significant correlation with PAS here is found for the baseline clinical T stage. If it's T2 and T3, 89% PAT CR. And if it is T4, then the PAT CR rate drops down remarkably and becomes only 17%. So to conclude the Infinity study by the GONO trial investigators, next slide. Preoperative tremelimumab and durvalumab for 3 months is safe, achieved promising eradicating activity in patients with resectable dMMR or MSI high EBV negative gastric and GE junction cancers. Of course, we are talking about 15 patients, 18 patients, so we require larger studies. But very soon, in the near future, chemotherapy-free immune checkpoint inhibitors-based strategies may represent a standard of care in this molecular subgroup. Again, less than 5% of patients or less than 10% of patients might be eligible for the approach in the entire gastric cancer population, but then in that 5% of patients, we might be able to have a chemo-free immune checkpoint inhibitor-based strategies. It's clear that the optimal combinations, the treatment duration, and the intent still needs to be established. Cohort 2 enrollment is ongoing, and protocol amendment has been done to exclude clinical T4 tumors, because the cohort 1 showed us that if it was clinical T4 lesion, then the PAT-CR rate is less than 20%, only 17%.
Bangalore. He's going to talk on newer updates in the management of first-line biliary tract cancer. This session is sponsored by AstraZeneca. Dr. Vijay Agarwal, sir.
Thank you, Dr. Srinivas, for giving me this opportunity, and the Horizon team for asking me to do this. Like Dr. Srinivas said, this is sponsored by AstraZeneca, and the slides are provided by them. After hearing to the excellent talk by the previous speakers, Krishna Prasad, mainly looking at the role of immunotherapy in gastric cancers and esophageal cancers, I think now we go further down the line to look at newer updates in the management of first-line biliary tract cancer, particularly in reference to the role of Imfinzi or durvalumab in biliary tract cancer. So the thing about immunotherapy is that it took off great in terms of the common diseases where immunotherapy is effective, like melanomas, lung cancers, kidney cancers, liver cancers, and now it's going down the line and has shown some good benefit in biliary tract cancer. So we're going to talk a little bit about that right now. So we know that biliary tract cancers are not uncommon in India compared to the Caucasian population, more common in places like Delhi and northeast of India. Unfortunately, 90% of the biliary tract cancers that are diagnosed are unresectable or advanced stages in India, and the median survival from the standard of care chemotherapy, which has been gemcitabine and cisplatin for ever since I've trained in oncology, has been less than a year or so, with less than 10% of the patients surviving for 5 years. Yes. So when you look at the current management of biliary tract cancer, and when I'm talking about current management, I'm talking about just prior to the immunotherapy taking center stage. This was the trial done in 2010, which was the ABC-02 trial, which compared cisplatin and gemcitabine versus gemcitabine alone, which was the previous standard of care, and showed improvement in overall survival as well as progression-free survival, with the median overall survival being 11.7 months for the combination arm and 8 months for the single agent arm, and PFS of 8 versus 5 months in favor of the combination arm. And since this study was published in 2010, there has not been a single study that has shown improvement in overall survival in biliary tract cancers till the immunotherapy came along. Another study that looked at gemcitabine and cisplatin versus gemcitabine and oxaliplatin doublet. So a lot of us tend to use oxaliplatin and gemcitabine instead of gemcitabine and cisplatin because of better tolerability. I've been looking at the outcomes in terms of overall response rates, event-free survival, overall survival. They were literally the same. So there's no difference between the two of them. So one could choose either a gem-cis combo or a gem-ox combo. I think that either of the two would be a reasonable first-line treatment option to go ahead with. So prior to the IOs, you look at the first version of the NCCN guidelines for last year, the preferred regime was gem-cis, which was the category 1 recommendation. And there were other chemo combinations. If someone did not want to use cisplatin for any reason, you could use gem-ox or any of the other combinations with 5-FU and oxaliplatin, 5-FU and cisplatin, and so forth. Coming to immunotherapy in first-line biliary tract cancers, this was a phase 3 randomized trial called the Topaz trial. It was a double-blind, placebo-controlled study looking at durvalumab in combination with the standard of care, which is gemcitabine and cisplatin, in patients with advanced biliary tract cancer. So inoperable biliary tract cancers, first-line treatment. So the inclusion criteria for the study design was patients should have had either locally advanced or metastatic biliary tract cancers, and they included intrahepatic, extrahepatic, or gallbladder cancers. Patients should have had a recurrence more than 6 months after curative surgery or last dose of adjuvant chemotherapy. If it was a relapse situation or upfront metastatic disease would be acceptable. Biochemically, patients should be okay with a serum bilirubin of less than 2 times the upper limit of normal, a good performance status. There should be measurable lesions. Okay, and the patients were randomized in 1:1, and there were 685 patients. Patients were stratified based on the disease status, whether they were initially unresectable or recurrent post-resection. And the second stratification factor was the location, whether it was intrahepatic, extrahepatic, or gallbladder cancers. Patients were randomized to receive either durvalumab with chemotherapy or chemotherapy with placebo. So chemoimmuno versus placebo chemo. And durvalumab was continued as maintenance till progressive disease, or placebo was continued till maintenance till progressive disease. The primary endpoint in this study was overall survival, with secondary endpoints being progression-free survival, response rate, duration of response, and safety. When you look at the patient demographics across both the groups, they were fairly well matched across both the groups. When you start looking at the stratification factors, when you look at the disease status, initially unresectable as well as recurrent, both were pretty much equivalent in both the subgroups. And when you look at the PD-L1 expression, again they were equivalent in both the subgroups, with about over 50% of them having more than 1% of PD-L1 expression. When you look at the amount of patients who received treatment, I think more than 99% of the patients allotted in that group went on to receive treatment. And a lot of them did receive subsequent treatment, about 42% in the chemoimmuno arm and about 49% in the placebo chemo arm went on to receive subsequent treatments. So this was the primary endpoint, which was the overall survival. The overall survival was in favor of the chemoimmuno arm, which is durvalumab plus gemcis, did better than chemotherapy alone. The median overall survival was 12.9 months for the combination arm versus 11.3 months for the chemotherapy alone, with a hazard ratio of 0.76, which was statistically significant. A few things I would like to point out here. One is that if you see the curves start to split only about 6 months' time. Okay, so till 6 months, the curves are kind of pretty much equivalent. Hazard ratio of 0.91, so non-significant. But once the curve starts to split, we can see that the patients who do well tend to have a durable response. And what is astonishing is that when you look at a 2-year survival, okay, 2 years, patients on immunotherapy, about 23% of the patients on immunotherapy are alive at the end of 2 years versus 11% who are on chemotherapy arm. So twice the number of people are alive at the end of 2 years in those who've received immunotherapy versus who did not. So that is quite significant on its own. When you look at the forest plot, the vast majority of the patients, irrespective of the stratification factor, benefited from the combination of immunotherapy and chemotherapy. When you look at the primary location, I think primary location does make a difference in terms of the prognosis and aggressiveness of the disease, particularly gallbladder cancer, we know do poorly, but all of them actually benefited from the combination of chemotherapy and immunotherapy. Again, irrespective of PD-L1 status, they all benefited from it, as well as the locations. When you look at the progression-free survival, the progression-free survival also was in favor of durvalumab and chemotherapy arm, as opposed to placebo and chemotherapy arm, with a median progression-free survival of 7.2 months versus 5.7 months for the chemotherapy alone arm. The hazard ratio of 0.75, which was statistically significant. Again, when you look at the 12-month progression-free survival, okay, about 2.5 times the number of patients who have not progressed as opposed to those on the chemotherapy arm. So 16% of the patients had not progressed on the chemoimmuno versus only 6% on the chemotherapy arm. Look at the forest plot, we see a similar picture that all subgroups of patients benefited from adding durvalumab to the chemotherapy. When you start looking at the overall response rates, so even though when we looked at the overall survival, the curves are splitting only after 6 months, when we look at the response rates, about a quarter of them, so 24% of them, responded to the chemoimmuno arm versus only 18% to the chemotherapy arm. Okay, and when you look at the durable response, so the patients responding for more than 12 months, 26% of them responded over 12 months in the chemoimmuno arm versus 15% in the chemotherapy alone arm. Again, patients who did respond tend to have a more durable response. And we've seen this in various other tumor types with immunotherapy. Unfortunately, in biliary tract cancer, we currently do not know which group of patients are those that actually respond, who are likely to have a very durable response. So this is the curve that is looking at those patients who are actually responding, continue to have a very, very durable response versus these patients. These are the yellow line group of patients who do respond to chemotherapy, but then kind of taper off very, very quickly. The worst ones are patients who do not respond at all. When you look at the toxicity, I think there was no new toxicity shown up with the combination of durvalumab with chemotherapy. Most toxicity is seen in both the groups were because of chemotherapy rather than immunotherapy. If you look at the number of patients who are needing who had toxicity leading to discontinuation of chemotherapy or death, there was no significant difference in either of the two groups. Again, when you look at grade 3-4 toxicities, there's not much significant between the two groups. This is just the same thing showing in a different manner. Most common toxicity was anemia, nausea, constipation, which are more common with chemotherapy rather than immunotherapy. When you look at the addition of durvalumab to chemotherapy, when you look at hematological toxicities, I think it's pretty much the similar across both the subgroups. And so is when you look at more than grade 3 toxicity, very few grade 3 toxicities in the chemoimmuno arm as opposed to the chemotherapy and placebo arm. So not much to kind of differentiate between the two groups of patients. When you look at overall survival for those patients who actually ended up with some amount of immune-related adverse events, there was no difference in the overall survival between the patients who ended up having immune-related adverse events as opposed to patients who did not have any immune-related adverse events. So both group of patients kind of benefited from the combination of chemoimmunotherapy. So when you look at the most recent version of the NCCN guidelines, pretty much immunotherapy is now here to stay. It's probably the first study after almost a decade that has showed overall survival benefit. So durvalumab and gemcitabine and cisplatin should now be the current standard of care, category 1 recommendation. And for any reason you cannot give immunotherapy, then gemcitabine and cisplatin continue to remain the chemotherapy of choice. So like I said, it's taken more than a decade to come from chemotherapy to chemoimmunotherapy, and I think that is now here to stay. So to conclude, durvalumab plus gemcis demonstrates statistically significant and clinically meaningful overall survival benefit. They appear to be effective irrespective of the molecular landscape of biliary tract cancers at this point in time, but I think more work needs to be done to be able to identify those subgroup of patients who are likely to benefit and possibly tailor-make further trials based on that. Durvalumab did not show any additional toxicity compared to that of chemotherapy alone, and DCGI has now approved durvalumab in biliary tract cancers in India, and we can comfortably give them to all our patients, and they will all benefit from it. And that is it from me. Thank you very much.
Thanks, Dr. Vijay, for that excellent presentation. Do you think taking TAP as one of the parameter, do you think that should we take it as is it a drawback or an advantage in this trial rather than the conventional PD-L1 expressions?
Yeah, no, I don't think so. We should look at TAP at all. I mean, the benefit was seen across the type of expression. So I think in my practice, if you have a biliary tract cancer, irrespective of the PD-L1 expression or the location, whether it's intrahepatic, extrahepatic, or cholangio or gallbladder, I think I currently offer it to all my patients.
And do you believe, because we are talking about metastatic setting, how long you want to give the benefit of IO in these patients?
Currently, the recommendation is still progression.
Okay. But many a times we don't, it's very, like, apart from the trial setting, it's very difficult to give. What is your practice?
Yeah, so currently I've not had a huge amount of experience. I've got about 6 patients in Finzi currently, but when they do progress, they progress within a year and a half. So I've not really had any experience with over 2 years. But if I were to take a guess, I think at the end of 2 years, I'll probably discuss whether the patient would want to stop or not. But short of that, I think I would continue.
And one of the questions from chat box is, what dose you use? I think, yeah, 1500 mg is in the trial setting.
Correct.
Do we have any modification or anything? Because many patients are not very affordable class of patients, what we generally see now.
Currently, because we have company assistance, because it is DCJ approved, I stick with the recommended dosage.
Okay. Thank you so much for joining us. That was an excellent presentation, Dr. Vijay.
Thank you for the opportunity, Dr. Srinivas. Thank you.
Thank you, Dr. Vijay. So then we'll move upon to next session, which is an international speaker program sponsored by Merck. I welcome Dr. Dan Edreka, professor and head of GI services in Israel. Dr. Dan Edreka, are you there?
Yes, I'm
Good
with
evening,
you.
sir. Good evening,
Good
sir.
evening. Good evening to you.
So I welcome you, sir, for this Congress. I would like to request you to start the session. All the stage is yours. Over to you, sir.
Thank you. Do you see my pointer?
Yes, sir. We can
Good.
see.
Okay, thank you. So I am going to talk to you in the next minutes on the sequence of treatment for wild-type RAS left-sided metastatic colorectal cancer. I'll look at it from a different angle than it is usually looked at. Well, it is not moving for some reason.
Technical team.
Yeah, it's not moving. The slides are not moving.
Ishika.
Yes, sir.
Oh, okay.
Professor has some difficulty.
No, I hope that it's okay. Fine.
So the volume is quite low, right?
It's okay. Thank you. Okay, so the metastatic colorectal cancer, the present standard of care asks us to start with the molecular examinations. We must examine the RAS, the BRAF, MSI high, and so on. Now, I'm going to concentrate on the RAS wild-type patients, and especially on the left-sided patients that are KRAS wild-type. We know that the standard of care for these patients is an EGFR inhibitor plus chemotherapy in the first line, followed by bevacizumab and chemotherapy. And this gives us some 36 to 39-month median survival for the patients. However, when we start with bevacizumab and chemotherapy followed by an EGFR inhibitor, this survival is somehow reduced by at least 6 months. So we learned this from the CALGB study, showing that indeed, starting with cetuximab in the first line, we can obtain a 6.7-month benefit, survival benefit, over starting with cetuximab in the first line. There is a survival benefit of about 11% between these two groups between 3 years and 5 years. So the FIRE3 actually showed a very similar figure. You see that if we start with cetuximab, the patients have a better survival compared to starting with bevacizumab in the first line. And again, the benefit in the favor of those who got cetuximab in the first line was between 10 and 14%. Now, a very interesting point is that in order to obtain this survival, we must continue the first line with the EGFR inhibitor and chemotherapy until progression, or of course, if there is toxicity or curative surgery, we can stop before. So continue this treatment was shown in the CALGB study and the FIRE3. Now, several months ago, we got the data from this study that was presented at ASCO with panitumumab in the first line compared to bevacizumab first line. And again, we obtained very similar results. The survival benefit of the panitumumab was 3.6 months. And again, we can obtain some 11% benefit at 5 years compared to bevacizumab. Now, how to explain this? Why bevacizumab is less effective than cetuximab in first line for left-sided RAS wild-type colorectal cancer patients? So the other question is why A followed by B is different from B followed by A. Now, or to put it differently, we give the first line treatment for several months here, is some 6 to 8 to 10 months. And still, if we start with cetuximab or an EGFR inhibitor, we obtain this result. If we start with bevacizumab, we obtain some 13% less survival of these patients. So how can we explain this? Why bevacizumab is not as effective, apparently, as cetuximab in the first line? This reminds us of a study where bevacizumab was given in metastatic breast cancer patients. At the beginning of the study in 2007, there was a very nice progression-free survival in favor of bevacizumab, almost 6 months. But the final survival was not statistically significant, so there was no survival benefit. The conclusions were that the initial therapy of metastatic breast cancer with paclitaxel plus bevacizumab prolongs progression-free survival, but not overall survival. And bevacizumab was probably of no survival benefit. In this study, the authors concluded that it is possible that resistance to bevacizumab results in relative resistance to subsequent therapies after the first-line treatment, or that there is a bound increase in VEGF on discontinuation of bevacizumab, which could result in a more aggressive disease, so the benefit of the PFS would be neutralized. So the FDA withdrawn the approval for this indication because of no survival benefit. So how can we explain this if it is a true phenomenon? In 2009, 2 studies show that there is an accelerated metastasis after short-term treatment with a potent inhibitor of tumor angiogenesis. Another study, there were back-to-back studies, show that anti-angiogenic therapy elicits malignant progression of tumors to an increased local invasion and distant metastasis. These studies show that after we administer bevacizumab, there is indeed a slower growth, there is a transitory tumor stasis or shrinkage and reduced tumor vascularity. And this is the good PFS that is obtained. But bevacizumab induces selection pressure on these residual cells, which probably induce a more aggressive and resistant clone that is selected. This can grow faster, can invade and produce metastasis, actually accelerating growth and finally reduced survival. The editorial said, is bevacizumab or are the VEGF inhibitors silencing or actually fueling metastasis? In 2013, another study showed that chronic inhibition of tumor cell-derived VEGF enhances the malignant phenotype of colorectal cancers. They show that inhibition of VEGF signaling accelerated migration and invasion in vivo. Another study showed that bevacizumab markedly increased the expression of hyaluronic acid. This induction caused increased tumor stiffness after VEGF therapy, and the hyaluronic acid impaired vascular function and drug delivery to the tumor and animal models of pancreatic and prostate cancer. So because of this increased hyaluronic acid here, there is impaired drug delivery after that to the tumor cell. And on the other hand, they showed that hyaluronic acid promoted migration and invasion tumor phenotype, enabling the tumor cells to migrate better toward the blood vessels in order to progress to invasion and metastasis. And now we remind, I have to remind what was said in the breast cancer study, that it is possible that the resistance in breast cancer was due to relative resistance to subsequent therapies. And yes, it may be because of the impaired drug delivery, or because bevacizumab could result in a more aggressive disease, as you see here. So if bevacizumab administration can select for more aggressive tumor clones. Can we see a faster tumor progression sometime after the treatment, resulting in a shorter expected survival? Let's look at all the studies that we know. Let's go to the CALGB study. Look at this arrow. You see that up to here, the two curves are apparently parallel, but at this point, they come apart. This happens at 24 months. At 24 months, the cetuximab or the EGFR inhibitor continues this way, but there is a faster progression or a faster, it's detrimental, somehow detrimental, more detrimental with the bevacizumab somehow. Let's look at the fire tree. Look at the same point of this arrow. Up to here, the two curves are parallel, and then they become apart. It happens at 24 months. What happened in the PIC study? Look at the arrow here. The same. The EGFR inhibitor fares better, the bevacizumab declines. It happens at 24 months. And let's go to the paradigm study, the one that employed the panitumumab, and you see that there is a crossover of the bevacizumab with the cetuximab. This is the cetuximab, this is bevacizumab, and this happens at somewhere at 28 months of survival. So it is strange. So I thought, let's go back to the classical IFL study in 2004. You remember there was placebo and IFL versus bevacizumab and IFL. This was the chemotherapy. You see that the placebo is a straight line, while the bevacizumab improves the survival of the patients, but suddenly, at some point here, there is a sudden decrease in the survival. It happened at 25 months. So how can we explain all this? Data suggests that increased tumor aggressiveness, fully expressed at about 24 months after the start of bevacizumab administration, may be a true phenomenon, because we see it in all the studies that employ bevacizumab. So in other words, it's possible that bevacizumab at the beginning, induced by the pressure that induced a new clone or a mutation that grew slowly, and at 24 months, it impaired, it was at the size that could impair actually survival. Is it possible? Yes. A doubling time of once every 10 days has been observed in treatment of resistant colorectal cancer, suggesting that under extreme circumstances, a growth rate that gives rise to a detectable metastatic mass from a single cell that has the new mutation, it's in only 12 months is possible. So within 1 year, from a single cell, we can get a metastasis that is clinically significant. So if A is followed by B is not equal to B followed by A, it may be because bevacizumab exerts a strong selection pressure on the tumor to express a more aggressive behavior that is not neutralized finally by cetuximab and panitumumab. This may reduce the survival by 6 months. Now, why, therefore, it is important in the first line to continue treatment until progression? Is it true? Is it correct? Well, if we stop this EGFR inhibitors before and we do not go until progression, we will actually start bevacizumab earlier, which brings the second line earlier. And of course, it reduces survival because now the tumor will go faster. So what is the importance of maintenance of this line? So if we continue this, we'll delay the initiation of bevacizumab second line. And indeed, look at this data. Patients were given here maintenance. Now, if they were given first FOLFIRI and cetuximab, then they were either given continuous cetuximab or observation. So they were given here maintenance. What happened with these two groups? Let's see. The group that started and continued with cetuximab had a maintenance, had a 25.6-month survival, while the observation group had only 19.7-month survival if the cetuximab was stopped earlier, which means another 6 months if we continue the cetuximab until progression. So this is the importance of maintenance. Now, therefore, FOLFOX and FOLFIRI plus an EGFR inhibitor should be given on the left side. On the right side, it's a different story. I'm not going into it. The second line should be indeed FOLFOX or FOLFIRI plus minus bevacizumab. And usually we administer in the third line either TAS-102 or regorafenib. Now, I would like to talk about the possibility of cetuximab rechallenge in the third line. We know that there are several studies that are shown here that used irinotecan and cetuximab in the first line. At cetuximab resistance, they changed to a cetuximab-free treatment, followed by cetuximab rechallenge with the same initial first line. It was shown that there is a 25% response. So how can we explain this? And this is the idea of cetuximab rechallenge. When we start, this is the tumor. We start with FOLFOXIRI, for example, with cetuximab in this case, and the tumor acquires with time, it becomes here, as you can see, resistant to cetuximab. At this time, it has only 4% KRAS mutated cells. So the question is, how can we obtain cetuximab resistance if only 4% of all the tumor clones are KRAS mutant? So 96% of the cells are KRAS wild type. Why they do not continue to respond actually to the EGFR inhibitor? So how to explain this paradox? That the presence of only 4% mutated cells is enough to induce cetuximab resistance in the remaining 96% of RAS wild-type cells. Now, when we stop actually here the cetuximab and we go to a cetuximab-free treatment, we observe that these clones actually go down and almost disappear. And the question is, well, but spontaneous tumor regression in cancer is an exception, is not a rule. So it doesn't make sense that these clones disappear spontaneously. They should persist. So how can we explain all this? And again, look at the data in different tumors, in different patients. The resistance to cetuximab is obtained at 3% mutated KRAS, at 3.5% mutated KRAS, even 1%, 0.2 or 1.4, and here at 8%. So a tumor actually, as we consider it nowadays, or as it was considered in the CALGB study, it contained less than a tumor that is RAS mutated contained more than 1% RAS mutated clones. If it contains less than 1%, it is considered a EGFR responsive tumor. So it is a KRAS wild type tumor. So 1% is the cut-off line. How come? Let's try to understand this. It's very interesting. Look at this. We start with a RAS wild-type tumor that has, let's say, has 1,000 wild-type cells and 6 cells that are mutated. It makes 0.6% of mutated cells, and this is considered a RAS wild type tumor because it has less than 1% of mutated cells. Now, we give cetuximab, and what happens? The tumor goes down, it is reduced. Out of 1,000 cells that are wild type, let's say that remained only 333. And the mutated ones, because they do not respond to cetuximab, went up. And now, let's say that we have 13 mutated cells. Now, it makes exactly 4% because 13 out of 333 is 4%. So at only 4% of these cells, all the wild types become mutated. How to explain this? How to explain this paradox? Well, this is explained by looking at the exosomes. Exosomes are intercellular transfers of transfer mutant RAS proteins between cells. Look, this is an exosome. And what is an exosome? This is a microvesicle released from the cell. And this is surrounded by a lipid bilayer, which is the cell membrane, with proteins which are derived from the cell of origin, serving as a mechanism of intercellular communication. These vesicles now will go to other cells and be implanted in these cells, like what I am going to show you immediately. So if a KRAS mutant protein was on the under the membrane, it will become incorporated now into these vesicles. So let's see. This is a cell that is resistant to EGFR inhibitors because it is KRAS mutated. It has a KRAS mutant protein. These are the sensitive cells, the wild type cells that will respond actually to cetuximab. Now what happens? From these cells come out these exosomes. These exosomes now will become incorporated into the sensitive EGFR cells. And these cells now acquire an oncogenic protein. They acquire this KRAS mutant protein that now will make them resistant to EGFR inhibitors. Now, strange, but look what happens. So if we have 13 mutated cells, they will transfer the KRAS to the rest, to the majority of the wild type remaining cells, and now all these cells apparently become resistant. This was only one cell resistant here, but now almost all these cells become resistant, although they do not contain the EGFR mutated DNA. They only contain now the KRAS mutated protein. So if we leave a cetuximab-free period and add another treatment, now these mutated cells will respond and will become less, while the wild type cells will increase in number because there is no cetuximab to inhibit them. Therefore, at this moment, we are again with 4 mutated cells within 600 wild type cells, which again makes it 0.66, which is the RAS wild type that was at the very beginning. So we have a RAS wild type at the beginning. It becomes a RAS apparently mutated tumor at resistance, but it can be reverted to a RAS wild type tumor if we administer a cetuximab-free treatment. So there is probably no preferential regression of the RAS mutant alleles upon cetuximab omission, but is there again dilution in the regrowing RAS wild type cells not inhibited in a cetuximab-free microenvironment. So to recuperate, a colon tumor is considered RAS mutated if it contains more than 1% RAS mutated clones. We administer cetuximab or an EGFR inhibitor, and there is an increase in these cells relatively. there is a relative increase, which makes them to be 4% of the whole tumor. At this point, if we use a cetuximab-free treatment, there is again regression or relative regression because the wild type are increased, the mutant are decreased, and again we have a wild type tumor. At this point, we can reintroduce cetuximab, and again we can obtain a response in some of these tumors. This is the basic explanation. Now, we have the cricket study, which actually used patients that were RAS wild type, gave them in first line cetuximab with chemotherapy. In the second line, when there was resistance, bevacizumab and other chemotherapy, and then they examined by liquid biopsy if the patients are now again RAS mutated or RAS wild type, if they were converted to RAS wild type. Indeed, 12 patients were still RAS mutated and 13 were RAS wild type. They gave to all these patients again the first line, cetuximab and irinotecan, and see the results. Those that converted back to a RAS or regained the RAS wild type, they had a 12.5-month overall survival. If they did not revert to a RAS wild type tumor, they had only 6.2 months overall survival, which is a difference of 6.3 months in the overall survival that is obtainable. So with a response rate of 21%. So what should be our third line treatment in patients who are KRAS wild type? Look, we know that cetuximab and irinotecan gave an overall response rate in the third line in these patients between 21 to 30%. At the same time, we know that regorafenib or TAS can give a response rate of 1% or 1.6% only. What is the overall survival that can be obtained? In the cricket study, there were two phases. In phase 1, it was obtained 9.8 months median survival. In the second one, 12.5. But what is the median survival that can be obtained with regorafenib or TAS? 6.4 months and 7.1. So in the third line treatment of patients with KRAS wild type tumors at the beginning, I think that it's better to try again the readministration of an EGFR inhibitor because it can prolong patients' survival. As you can see, from almost 11 months compared to 6 or 7 months only. So this is my conclusion, that in the first line, of course, we give an EGFR inhibitor and FOLFOX/FOLFIRI. In the second line of the RAS wild type patients on the left side, we revert to FOLFOX bevacizumab. The option of TAS and regorafenib is there, but cetuximab rechallenge should be probably a good possibility for these patients. So in conclusion, I would like to thank you and to consider that in the first line, probably the EGFR inhibitor is better than the bevacizumab, probably because bevacizumab induces some tumor that is more aggressive and with a faster growth after 2 or 3 years, while for this third line, we should consider probably the reintroduction of an EGFR inhibitor. Possibly we can help ourselves with a liquid biopsy. Thank you very much.
Thank you, Professor, for that excellent presentation. Now we have Dr. Ravi Tippeswamy who would like to ask few questions. regarding this one. Dr. Ravi, are you there?
Yes, sir, Srinivas. Yeah, thank you.
Over to you, Ravi.
Yeah, thank you, Professor. I think that was a wonderful explanation of why we should use EGFR inhibitors in the first line in wild type. So practically, we'll discuss in the next 15 minutes or so some of the burning questions what we face in our day-to-day practice. So nowadays we are doing MSI for all the patients in metastatic colorectal cancer. So what is your usual practice in MSI high tumors metastasis? Role of neoadjuvant immunotherapy is feasible, and do you consider in your practice regarding neoadjuvant immunotherapy?
Yeah, well, can I have the screen? I would like to answer by a short, very short explanation. I think that we have to understand, yes, of course, I am using for MSI high tumors, colon cancer or the other cancers, I use the immunotherapy, but I would like to explain short, in a very short, why it helps, why it works in all the MSI high tumors. Look, we know that tumors start by a cell that has a mutation, then new mutations appear and new populations appear, as you can see here. So we have one population, the initial population, a second population, a third one, fourth one, and so on. Many times we have more than 10 populations in a tumor that is already metastatic. So what we have actually is a tumor like this. Or we can see it that the clonal evolution of the tumor is, as I showed you here. Now, there is a big difference between the tumor at the very beginning, as you can see here, and the tumor that is already metastatic. In this case, there is only one clone or two clones, while here there are a lot of clones that appear. So there is a big difference between this part of the tumor and this part of the tumor. Now, why, therefore, this part is better responding to immunotherapy than this part? I think that you can already understand this just from looking at this picture, but I'll try to explain it even deeper. Well, we have a tumor cell. The T cell recognizes it by its T cell receptor, and this is a signal of recognition. Then the T cell binds to this tumor cell, and now, as you can see here, on the surface of the T cell are all kinds of inhibitors. These are the checkpoints. If you press on them, like on this brake, you inhibit the cell. But if they are not compressed, all these are kind of brakes of this T cell. But if you do not compress them, there is a signal of activation, and the T cell will kill the tumor cell. It will cause apoptosis. But look what happens. We have the first cell, the first clone here, the first population. It can, on its surface, it can acquire PD-L1. PD-L1 can inhibit PD-1. Let's consider PD-L1 as a leg that can compress the brakes like this. In this case, indeed, there is no signal of activation because the activation is inhibited, and there is inhibition of this activity of this T cell. Now, what do we know? We have nowadays pembrolizumab and nivolumab, which can protect this PD-L1, this brake, from being compressed by the PD-L1, the leg that is on the tumor cell. And because it is protected, the leg, the PD-L1 cannot compress it. This is why the cell, the T cell, remains active. On the other side, we have atezolizumab, avelumab, durvalumab, which compress or prevent this leg from compressing PD-L1. And in this case, if we use these agents, either anti-PD-L1 or anti-PD-L1, we obtain signal activation, and the T cell can kill the tumor cell. Now, let's see what happens. A second clone we may acquire now a new leg, a new inhibitory activity. The CD8086 can inhibit CTLA4, but now we can use ipilimumab and prevent this. But what happens then? Then appear another clone with another checkpoint inhibitor, another inhibitor on the tumor cell surface. It can inhibit TLT2. Then VISTA. VISTA can inhibit VISIG3, or GAL9 can inhibit here TIM3. So although we administer immunotherapy for these two checkpoint inhibitors, with time, we do not have any agent in order to inhibit the other inhibitors of the T cell. So at the very beginning, it is very easy to inhibit because there are no other checkpoints that inhibit the T cell. More than that, look what happens. This is the T cell in stage T1. With time, we are going to T4, there is much less T cells, cytotoxic T cells in the microenvironment of the tumor. Look at this. These are the T cells in T1, but with time in T4 tumors, there are even less, much less T cells. It reminds us of what we heard this afternoon, that in T4 esophageal tumor cells, the immune therapy is not so effective as in T1 to T3. And why this? Because look, with time, the tumor acquires more and more inhibitory effects. But as I showed you, in T1, there are a lot of T cells, but with time, they are less and less. And if we overlap this over the other, actually, what do we obtain? That at the very beginning, in the neoadjuvant time, we have a lot of T cells that can be active and very little mutations or very little checkpoints that can inhibit them. While in the metastatic setting, as you can see here, we have little T cells in the microenvironment and many inhibitory checkpoints. So malignant tissue continually mutates with time, increasing with an increasingly selective pressure develops more effective escape mechanisms. Now let's go to the colon cancer in the first-line therapy. We have two studies. In one, we gave pembrolizumab, and you see that the response was only in 50% of the patients. All those here are resistant because they probably have not only PD-L1 on the surface, these tumors, but also other immune checkpoints that inhibit them. If we add nivolumab and ipilimumab, we have less resistance than with only one drug, because now we can inhibit both the PD-L1 and the CD8086. So there is a better response. Look what happens here. This is the response rate with pembrolizumab in the metastatic patients. Some tumors are more responsive, but some have more and more mechanisms. And as you see, the red part is the non-responsive clones that do not respond to the pembrolizumab or ipilimumab. Look what happened in first line in the niche study. This study is MSI high patients that are given immunotherapy for only 4 weeks before immunotherapy, before operation. So at this time, they are given 2 drugs, ipilimumab and panitumumab. And look what happens. The responses are impressive. 67% PCR for these patients in an early stage. And why? Because in the early stage, we have a lot of immune cells that are active and very little immune checkpoints that inhibit them. So looking at the metastatic colorectal cancer, there is a lot of inhibitory activity here because of all these new clones that developed new checkpoints that inhibit the immune cells, but in the early stages, we have very little inhibitory effects because we are in this stage where we can administer the immunotherapy that can affect these cells. So the earlier the tumor is treated with immunotherapy, the higher the chance to have sensitive clones and to achieve a response. This is what happened also in rectal cancer, as you remember, and there is an article in New England saying that 12 patients with MSI high that were treated with dostarlimab for 6 months achieved, all of them, complete response. And now we can understand why. These are all these patients, they always achieved a complete response with little adverse effects. So I think that this explains why actually the neoadjuvant therapy or therapy in the early stage of the tumor can give such impressive results in all the tumors, not only in colorectal cancer.
Thank you, Professor. The other thing is nowadays we are doing the broad spectrum genomics for all metastatic colorectal like lung cancer, and many of the time we are picking this BRAF mutation. So how do you see the treatment landscape in BRAF mutant metastatic colorectal cancer changing in the next few years?
Well, I think that we know nowadays, just a moment. Well, I think that we know nowadays that in the first line, we usually use FOLFOX and bevacizumab. And in the second line, we know that we have to give encorafenib and cetuximab or other BRAF inhibitor. Now, the question is, what are we going to give? Can we move the BRAF inhibitors to the first line? So now there is a study which is called the Breakwater study that is trying to answer this question, and it's trying to give a doublet in the first line or a triplet, a doublet and chemotherapy, or chemotherapy plus bevacizumab. And we know already from the initial data that there was an exam in the doublet and the doublet plus FOLFOX/FOLFOXIRI. And look what is the data. If we use a doublet and FOLFOX, we can obtain a progression-free survival of 9.9 months for these patients with a response rate of 68%. If we use the same doublet, but FOLFIRI, the survival or the progression-free survival is more than 12.5 months. So I believe that in the future, this line, a doublet plus FOLFIRI, will be probably the first line treatment in the BRAF mutant patients with colorectal cancer. Yes,
yeah.
Thank you.
Thank you, Professor. And now I think trastuzumab deruxtecan has made a big impact in our day-to-day practice. So do you check HER2 mutation in metastatic colorectal cancer on a regular basis, and in what lane you test? And how do you see the changes in metastatic colorectal cancer, especially in the third line setting?
Yes, yes, of course. I do examine the HER2 overexpression in metastatic colorectal cancers, and it's 2 to 6% usually. Now, just to understand what happens here, if we have a cell, and this is the EGFR receptor, EGFR activates the cell, and we have activation of the BRAF, ERK, and then of the AKT/mTOR. They cause proliferation, survival, invasiveness, and so on. If we administer cetuximab, we inhibit these activities, and that's what happens. But in this 2 to 6% of the tumors, there is upregulation of HER2. Now, HER2 has the same activity like EGFR. It can activate RAS, and it can activate at the same time AKT and mTOR, and it can obtain the same results. Therefore, if we administer cetuximab to a tumor that has a HER2 upregulation, we cannot inhibit this cell. There is cetuximab resistance because the cell continues to be active and proliferate. Now, what do we do actually? We administer trastuzumab, which inhibits the HER2, but at the same time, if the EGFR is not inhibited, it can regain its activity. So what can we do? We can add another drug. It's lapatinib. The lapatinib will inhibit here the HER2 and here the ATP binding pocket. And now the combination of trastuzumab and lapatinib will inhibit these cells for a while. Now, the Heracles trial used this combination just to remind you that if a cell has a KRAS mutation, the inhibition by trastuzumab and lapatinib will not work because the KRAS mutation will continue the cell proliferation, as you can see here. So we cannot use trastuzumab lapatinib in KRAS mutant cells. So there are two studies indeed, and I have patients that I used both with combinations of either trastuzumab lapatinib or pertuzumab trastuzumab. These studies show that there is a survival probability in the third line with trastuzumab lapatinib in these patients of 9.3 months or 11.5 if we use trastuzumab and pertuzumab. So I do like to do that. Now we have also the trastuzumab deruxtecan. What is trastuzumab deruxtecan? Is trastuzumab the same antibody, but deruxtecan, a drug that is like irinotecan, is bound to this complex, and now we can obtain, as you can see here with trastuzumab deruxtecan, as shown in Destiny study, 15.5 month median survival benefit in the third line. I think that it is very impressive. So with trastuzumab, pertuzumab, we can obtain 11 months, and with trastuzumab deruxtecan, another 15.5 months. Indeed, here we obtain 11 months, but those that are resistant to trastuzumab pertuzumab can be given trastuzumab deruxtecan, and again we can obtain another median survival that is very impressive. So yes, for these patients, I think that if they are HER2 amplified, we should use trastuzumab either with pertuzumab or lapatinib, and when this become resistant, we should go to trastuzumab and deruxtecan. And that's exactly what I am doing.
Yeah, thank you, Professor. And over to you, Srinivas.
That was an excellent interactive session, sir. You answered so well, and it is so clear. The line of therapies, how to choose first line, second line, third line. What are the benefits? What are the gains in these patients when we offer them all these line of therapies sequentially? And what is the importance of giving first line anti-EGFR rather than anti-VEGF in these patients? You have educated us so well, and it has become very clear how to sequence these patients. Thank you, Professor, for that wonderful presentation and interaction. I thank you for joining us. Thank you so much.
Thank you. Thank you.
So next we will move upon to the next topic, long-term outcome results from NRG G1002 phase 2 trial using total neoadjuvant therapy in locally advanced rectal cancer. Dr. Rachan is a senior medical oncologist at Mangaluru. Dr. Rachan, are you there?
There, I'm there.
Over to you, Rachan.
Yeah. At the outset, I would like to thank the organizers for providing this opportunity. So today's talk is about long-term results of NRG GI-002 phase 2 clinical trial platform using total neoadjuvant therapy in locally advanced rectal cancer. Next slide, please. So as we know, in all rectal cancers, especially locally advanced, T3, T4 or node positive, standard treatment approach is chemoradiotherapy followed by surgery and chemotherapy. So totally is an accepted practice option to ensure high-risk patients receive systemic therapy. Just a second. So with this approach, we know that only 20% pathological CR rates is achieved and 25 to 70% do not receive adjuvant systemic therapy. So NRG GI-002 study was designed to rapidly seek activity signals for newer agents in total neoadjuvant therapy. Next slide. This study schema, it is a platform study. Nested randomized phase 2 experimental arms were there, where high-risk stage 2 and stage 3 patients having low-lying, bulky N2 or patients who require abdominal perineal resuscitation were studied. So this study had a control arm where FOLFOX 6 for 4 months, followed by chemoradiation and surgery, were compared against. So there was also a provision for a third experimental arm with the newer modalities of drugs and novel agents at a later date. Next slide. So in all arms received chemo followed by chemoradiotherapy 3 to 4 weeks later, and 6 to 8 to 12 weeks later surgery. In experimental one arm, hypothesis was PARP inhibitor can enhance RT-induced synthetic lethality. Veliparib was used 400 mg BID from first to last day of RT. And experimental arm 2 had a hypothesis saying that RT can enhance anti-tumor immunogenicity via release of new antigens and immunogenic cell surface marker upregulation. In this arm, pembrolizumab was used 200 mg IV 3 weeks into 6 doses starting on first day of RT until completion of radiation, completion of chemotherapy and radiation. Next slide. So eligibility criteria was biopsy proven stage 2 or stage 3 rectal adenocarcinoma, PCOG PS 0 or 2, and tumor must be locally advanced by at least one criteria, that is distal location, that's a clinical T3 T4 tumor less than 5 cm from anal verge of any nodal status, or a bulky disease with a clinical T4 with the majority of the tumor less than 12 cm from the anal verge, or the tumor or the evidence that tumor is adjacent to the mesorectal fascia, that is within 3 mm of the mesorectal fascia. High risk for metastatic disease, that is more than 4 regional lymph nodes considered as N2, and are not a candidate for sphincter-sparing surgical resection, that is patients requiring API. And stage of primary tumor is determined by preferably by MRI or endoscopic ultrasound, and should have adequate organ function, should be treatment naive and a candidate for surgical resection. Next slide. So endpoints and statistical consideration. The primary endpoint was neoadjuvant rectal score, which is a scoring system based on GCR3 and contrast studies, where NAR score, neoadjuvant rectal score mean was about 14.32, and
Technical team, please, can you please check Dr. Achan is there?
I'm audible now. Hello?
Yes, sir. It's audible. Sir, your voice is not audible now.
I think there's connectivity issue at his end. Hello?
Yes, ma'am. I think he's stuck.
He is rejoining as a panelist.
Yashika, can you please promote him?
Already done. He's rejoining. He is rejoining, yeah. Hello, sir. Shika, please call, sir. Okay, ma'am. Hello, sir. Can you hear us? He's not picking up, ma'am. Okay.
I think, he's
So
not
we-
taking the call. Is he not taking
Yes,
the
sir. Yes, sir. He's not taking up the call.
I think we'll let with if time permits, we'll keep this session later.
Yes, sir.
I think we'll move to the next topic.
Move to the next session. Yes, sir. Sure.
Dr. Abhilash is our colleague and medical oncologist, consultant medical oncologist at Bharat Hospital. Dr. Abhilash, are you there? Dr. Abhilash?
Sir, next talk is Dr. Raghunandan, sir.
So Raghunandan will join last. He called me. He has some emergency in the hospital. Is going to join after Dr. Abhay's session.
Hello, sir.
Dr. Abhilash? Yeah.
Yes, sir. I'm here.
So Dr. Abhilash is there. He's going to present sunlight study, trifluridine tipiracil with bevacizumab in third line refractory metastatic cancer. This session is sponsored by NATCO. Dr. Abhilash is a consultant medical oncologist at Bharat Hospital, Mysuru. Over to you, Abhilash.
Yeah, please, can you share the presentation?
Sir, okay, we'll share you.
Hello, can you see the slide, sir?
Yes, sir.
Good evening, everybody. First of all, I would like to thank the organizers for the opportunity and Dr. Srinivas sir. So my topic for presentation today is the sunlight study. which is a phase 3 randomized study, which is trifluridine with the tipiracil plus bevacizumab for the third line treatment of refractory metastatic colorectal cancer. So coming to the rationale why the study was conducted was, as we all know, that trifluridine is an orally administered combination of trifluridine, that is a thymidine-based anti-neoplastic nucleoside analog, and tipiracil, that is a thymidine phosphorylase inhibitor that increases the bioavailability of trifluridine by inhibiting its breakdown. So third line trifluridine has significantly improved the overall survival, and it also had a favorable safety profile in the RECORE study. That was a phase 3 study, which was a placebo-controlled study. So also the results from several phase 2 and single-arm studies have shown that the combination with the bevacizumab has improved overall survival with a manageable safety profile. So Sunlight study was designed to confirm the efficacy and safety of trifluridine tipiracil with bevacizumab in patients with refractory metastatic colorectal cancer in the third line. So it was an open label randomized study where patients who had received 2 prior treatment regimens, including a 5-FU fluoropyridine and oxaliplatin irinotecan, either anti-VEGF or EGFR if it is a wild type, and those who had progressive disease with a known RAS status with a ECOG performance status 0 to 1, and stratification factors which were involved was geographical region, and the diagnosis of first metastasis, that is less than 18 and more than 18 months, under known RAS mutation status, where patients were randomized to receive trifluridine tipiracil orally. The dose was 35 mg per meter square twice daily for days 1 to 5 and 8 to 12, that is weekly 5 days every 28 days, along with bevacizumab 5 mg per kg with day 1 and day 15 every 28 days. And the primary endpoint of the study was overall survival, and secondary endpoints were progression-free survival, disease control rate, objective response rate, safety profile, and quality of life. So follow-up was done every 8 weeks to look for any radiological progression and for survival status. So the key baseline characteristics in both arms, like age, the median age in the patient study group was 62 years and the control group was 64 years. And all the key other baseline characteristics like region, primary tumor localization like right and left sided cancers, and time from the diagnosis of first metastasis, and the RAS status, and prior treatment with anti-VEGF and ECOG performance status. Most of the patients were 0 and 1, and all those factors were matched. So as we can see, the overall survival in the full analysis set, that was the primary endpoint. So in the study arm, the median overall survival was about 10.8 months compared to the control arm, where it was 7.5 months, and 6 months overall survival rate was 77%, and 12 months overall survival rate was about 43%, with a hazard ratio of 0.61. Before initiating the study, they had statistical significance of they wanted to achieve hazard ratio of 0.7, but they were able to achieve hazard ratio of 0.61 with a significant p-value. So in the forest plot, as we already discussed, the pre-specified subgroups, all the subgroups, most of them have shown clear benefit with a trifluridine tipiracil with bevacizumab arm. So with respect to receiving bevacizumab or wild type or mutant RAS, all the factors were matched, and there was clear benefit with the bevacizumab arm. And coming to the PFS, progression-free survival also, the median PFS was 5.6 months versus 2.4 months, and 6 months and 12 months PFS rate was 43% and 16% with a hazard ratio of 0.44. We can see the curves are widely separated. Even the pre-specified subgroups, as we discussed for overall survival, it has shown a clear benefit with respect to the bevacizumab arm. So coming to the objective response rate and disease control rate with respect to tumor response. So we can see the study group has shown clear about 5.4% clear benefit in objective response rate, and it was about 30% improvement was seen with respect to disease control rate in the tipiracil and trifluridine arm with bevacizumab. So they also had included quality of life index, and they have calculated time to deterioration in the global health status. So the median time to deteriorating global health status is about 8.5 months versus 4.7 months with hazard ratio of 0.5. So also the time to worsening to an ECOG status of performance status of more than 2. So this has also shown clear benefit with respect to the study arm with median time to worsening in these 9.3 months versus 6.3 months with hazard ratio of 0.54 with a significant p-value. So coming to the safety, so overall treatment related side effects including like trifluridine, tipiracil, and bevacizumab. The trifluridine related side effects and the bevacizumab related side effects were there was no much difference between the treatment arms, and there were no treatment related deaths. So there were withdrawals from the study, like the numbers are equal, but dose reductions was major in the treatment arm. About 16% dose reductions were done in the trifluridine tipiracil with bevacizumab arm compared to the study control group. So the treatment related more side effects, the most common side effects were hypertension, which was seen in about 10% in the study group, and nausea and neutropenia were more common in the combination group. So there were no treatment related deaths, but there was one case of febrile neutropenia in the trifluridine tipiracil with bevacizumab arm, compared with 6 cases were reported in the control group. So coming to the conclusion, so trifluridine tipiracil plus bevacizumab, they have resulted in a significantly longer overall survival and progression survival and improved disease control rates with the tablet alone. So this is the first trial in the setting of metastatic refractory colorectal cancer to demonstrate an improvement in the overall survival with an active control. The other studies, they were all, most of them were placebo control studies, and the survival was noticed in all the clinically relevant subgroups. So they also included worsening of baseline global health status, since most of the patients are elderly and post 2 to 3 lines of chemotherapy. So ECOG performance status was like the duration was significantly delayed in patients with the trifluridine tipiracil plus bevacizumab arm, and the safety profile was also manageable, and they were consistent with individual safety profiles, as we all know, with bevacizumab and the trifluridine arm. So this presents a new standard of care for the treatment of patients with refractory metastatic colorectal cancer who have progressed after 2 lines of therapy. And now this has been included in the NCCN guidelines as well. So for most of the patients, I think those who can take orally, I think this is the best option in the 3rd line. Thank you, sir.
Thank you, Abhilash, for that excellent presentation. I feel now we have at least a window of opportunity to offer them something at 3rd line.
Yes.
3rd line regime such that which has a longer OS and PFS, so which we didn't have
Yes,
ever before, because see, regorafenib, as Professor showed in his slides, the survival is like 3 months, 4 months,
Yes,
something like that, whether you take regorafenib or any other treatment in 3rd line. Now this is opening something, a new window which can give such a good OS benefit and PFS benefit. I think this paper was very encouraging, and this was presented in plenary session in ASCO Gastric Symposium.
Yes, sir.
I think a lot of newer studies will come based on these, and I think now 3rd line and 4th line, the future is bright. Actually, I feel.
Yes, sir. Yes, sir.
Thanks
Definitely.
for that presentation, Abhilash. Thank you so much.
Thank you, sir.
Next speaker, Dr. Guru Prasad Bhatt, a senior medical oncologist, Mangaluru. He's going to present preoperative chemotherapy prior to primary tumor resection for asymptomatic synchronous unresectable colorectal liver limited disease. Dr. Guru, are you there?
Hi, Srinivas. I'm there.
Hi, Dr. Guru.
Hi,
I
Srinivas.
welcome
Can you
you to
share the PowerPoint, please?
Yeah, Yashika, can you help him?
Thank you, Srinivas. Thanks for
Yes, sir.
organizing such a
Thanks,
wonderful.
Guru. Thanks for joining. Thanks, Guru. Please go ahead.
Sir, we are sharing 1 second.
Yeah. Good evening. Good evening, one and all. Am I audible?
Yes, Guru, you are audible.
Yeah. Good evening, one and all. This is a common problem which we face in clinical scenario. That is, a metastasis is there, liver metastasis there, which is not resectable, but the primary is resectable. What to do next is a common problem we face. So we need a phase 3 trial to say how to go about it. So this is one of those trials, multi-center randomized trial, recut, which is a pre-operative chemotherapy prior to the primary tumor resection versus plain surgery and or just chemotherapy. So this is one of those trials which helps us clear the dilemma of how to go about when there's a liver metastasis which is unresectable, but the primary is resectable. So next slide, please. So colorectal cancer with asymptomatic resectable primary tumor, but synchronous unresectable metastasis, how to go about, whether it is primary tumor resection or primary chemotherapy followed by tumor resection. So which one to go about? So we have both pros and cons for it. So primary surgery, we have some trials which will say that they are better, whereas primary chemotherapy followed by surgery, also we have trials which say they are better. So how to go about it? So this is one of those trials which will help us clear our get a better idea. So the trials which meta-analysis are there, which says that chemotherapy versus primary tumor resection and chemotherapy, the primary tumor resection is favorable in the meta-analysis from Miami. We also have a lot of other meta-analysis too, whereas I'll be speaking on the trial which favors chemotherapy. So next slide, please. The trial had 2 arms. In that, the patient, one of the arms underwent chemotherapy for 6 cycles, followed by primary tumor resection, whereas the other arm underwent primary tumor resection itself. So one arm had neoadjuvant chemo, followed by the resection of the primary. Other arm had directly surgery. So they wanted to see what is the difference. This is a common problem which we all face as medical oncologists, what to do for the resectable primary. The Mets may not be resectable, what to do for the primary. So this is a phase 3 trial, multicentric trial, and which compared primary tumor resection chemotherapy versus upfront surgery for metastatic colorectal cancer in patient with asymptomatic resectable primary tumors. And so this was taken from China, where there were 4 centers enrolled in the trial. The primary endpoint is PFS, because we know in metastatic setting there are multiple lines of treatment, so they take primary endpoints as a endpoint. Secondary endpoint was overall survival, overall response rate, and multiple other things also. So this is the trial. Next slide, please. It was well balanced on both arms. A total of 320 patients were enrolled in the study. Both arms had 160 patients each. And finally, there were 310 patients evaluable. 10 patients were not evaluated later. Next slide, please. So the baseline characteristics were well balanced in both the arms. Based on age, based on the sex, based on the performance status, based on whether they were right-sided tumors or left-sided tumor, based on number of metastases. So it was well balanced, and the chemotherapy given also was pretty well balanced, with patients either receiving cetuximab or bevacizumab based on the site of the tumor, and clinical score also. Next slide, please. So in the primary endpoint, the PFS was a primary endpoint in this study. The median PFS was 10.5 months in the just the primary surgery arm versus the that is 10.5 months in the patients who received chemotherapy followed by surgery, and it was slightly better compared to just surgery alone. So this is what they have shown. The PFS is better in patients whom undergo first chemotherapy followed by surgery. This is what been highlighted in this slides too. The PFS of 10.5 months versus 9.1 months. Surgery alone arm had a PFS of 9.1, whereas those who received chemotherapy followed by surgery, they have better PFS. Next slide, please. So this showed the subgroup analysis also was favorable across age, across the performance status, and left side tumors and wild type KRAS. So it was showing that this is a better outcome for most of the patients. Next slide. Even the secondary endpoints, that is overall survival, overall response rate, was better. The median overall survival in the patients who received chemotherapy was around 29.4 months versus 27.2 months in the patients who just received upfront surgery. So even the median overall survival was better. This was with the follow-up time of 36 months, up to 3 years. Next slide. Other parameters which were taken in the secondary endpoints also showed that pre-op chemotherapy followed by surgery was a much better way of treating metastatic colorectal cancer, where the primary is resectable, but the liver metastasis is unresectable. There were adverse effects related to chemotherapy, yes, but yeah, these were well manageable. Next slide. Conclusion: for asymptomatic synchronous unresectable liver metastasis with conversion therapy, pre-op chemotherapy improved the PFS compared to upfront surgery alone. So pre-op chemotherapy demonstrated a better disease control rates and trends toward better overall survival compared to upfront surgery alone. So even conversion rate to hepatotoxic surgical complication, the chemotherapy toxicity was not clinically significant. So this study highlighted that in a patient with a liver metastasis where the primary is resectable, kindly go ahead first with chemotherapy followed by surgery. Thank you. Thank you, Srinivas, for giving me this opportunity to speak. And I'm sorry for the background noise.
No issues, Guru. It was very clear. It was very audible. It went nice. Thanks for the presentation. I think what it highlights is a multidisciplinary tumor board is what very much essential when it comes to when a case comes to the clinic, when a case comes to the surgeon. It is not essential that they do an upfront surgery. When they involve a multidisciplinary tumor board, probably a lot of discussion happens, and neoadjuvant therapy is something very useful in these situations, as we have shown in the data, isn't it?
Yeah, the thing is, this is very we have very few cancers where the resection can be done, where in metastatic setting. Colorectal is one of them, where they feel the primary can be resected. So there also, that's a confusion, because the surgeon will see it's a metastatic disease, but they will go ahead with surgery. So this is an area of dilemma. So this trial highlights that even in those cases, kindly gives chemotherapy front and followed by surgery.
But look at those R0 resections; all are numerically pretty higher, better in when you subject a patient for chemotherapy. I think that's a take-home message.
Take-home message, yeah.
Thank you. Thanks, Guru. Thanks for that wonderful presentation. Thank you so much for joining.
Thank you, Srinivas. Yeah.
So we'll move to the next topic. Dr. Abhay is going to present 5-year follow-up data of phase 3 trial 4 versus 8 course of S1 therapy for patients with stage 2 gastric cancer. Dr. Abhay? Dr. Abhay, are you there?
Sir, Dr. Abhay is not there. So Dr. Rachan is ready for the speech.
Yeah, then I think we can go ahead with Dr. Rachan's presentation. Dr. Rachan, please go ahead with your presentation.
Yeah, at the outset, I would like to excuse me for the technical glitch. My phone switched off and I lost the internet connection. So I was unreachable for that reason. So this is regarding total neoadjuvant therapy and experimental this neoadjuvant total neoadjuvant therapy followed by surgery versus total neoadjuvant therapy with the radiation arm adding veliparib or pembrolizumab against the comparator arm. So in this primary endpoint was NA and neoadjuvant rectal CR rates, complete recurrence and symptom preservation and compliance and hello. Next slide. Next. This study enrolled in experimental arm 1 more than expected 178 patients and earlier. And next slide, please. So in the experimental 2 arm, there were experimental 2 arm. There are 185 patients enrolled, more than projected. Next slide, please. The experimental 1 arm which looked at veliparib. So less than 50%, less than 50 years, and 27 and 31% in the 27% in the veliparib arm, and total was 31. Most of the patients were Americans, and Asians were very few. Next slide. Coming to patient characteristics, most of the patients had a bulky disease. N2 disease was seen in about 43% of the patients. About APR patients were about 50% each arm. Next slide, please. Now, regarding the results, at the median follow-up of 3.5 years, a neoadjuvant rectal score in the control arm was 12.5. In the veliparib arm was 13.3. Mean difference was 0.8. It was not statistically significant. And DFS and OS was also not statistically significant. DFS years was 67% and 60% in veliparib arm, and OS was 92% in control arm versus only 85% in the veliparib arm. Coming to secondary endpoints, pathological CR rates were slightly higher, not significant, and clinical complete response was also higher, but not significant. Next slide. So the DFS and OS curves, as you can see, the control arm did better than the experimental arm. Hazard ratio was 2.13. That is the experimental arm was 2 times worse than the control arm. Next slide. Coming to experimental arm 2, where they you studied pembrolizumab combined with the total neoadjuvant therapy. This study also had a male to female ratio about 60 to 30%, and about 50 less than 50-year age group was around 30%, and it was masked. Both the arms are well masked. Next slide. Next slide. In the new and updated results, at the median follow-up of 3.15 years, to neoadjuvant rectal score was mean 14.4 in control arm versus 11.5 in pembrolizumab arm. 3-year DFS was 64% in control arm versus 64% in pembrolizumab arm. And 3-year overall survival was 87% versus 95%. In this arm, the pembrolizumab arm had a statistically significant overall survival advantage, but it surprisingly did not show local endpoints like neoadjuvant rectal score or even the DFS at the end of 3 years. So coming to this pathological CR, as you can see, it's 29.4 versus 31.9%. Complete clinical response was 9.6 versus 13.9%. R0 resection was 89.4 versus 94%. And sphincter sparing in surgery. It was also not statistically significant. Next slide, please. So only the OS curve had a significant, statistically significant improvement in OS. DFS curve is almost same. Next slide. To conclude, this NRG GI 002 study provides TN total neoadjuvant therapy outcomes data from a multi-institutional national clinical trial for benchmarking in future locally advanced rectal cancer trials. In this, the experimental arm veliparib nor pembrolizumab, when added to total neoadjuvant therapy, significantly improved short-term outcomes in unselected patients. Pembrolizumab, when added to total neoadjuvant therapy, was associated with improved 3-year overall survival, despite no significant improvement in neoadjuvant rectal score and other short-term outcomes or disease-free survival. So molecular interrogation of tumor and circulating biomarkers is ongoing to identify subgroups who might benefit from these targeted treatments. Why pembrolizumab had a higher 3-year overall survival despite not showing increase in neoadjuvant rectal score or DFS, and whether adding veliparib in certain subsets will benefit these patients. So that has to come with the available data later. Thank you.
Thanks, Dr. Rachan, for that wonderful presentation. I think more data is required, or probably more better predictive markers, biomarkers should be made available in order to predict who are the subset of patients who definitely going to do better with these regimes. That's what I understand from your talk. Next presentation by Dr. Raghunandan. Dr. Raghunandan is a senior surgical gastroenterologist at People Tree Hospital. He is going to present OPERA phase 3 trial. Do non-operable modality treatment in rectal cancer compromise chance or cure a final surgical salvage therapy? Dr. Raghunandan, are you there?
Yes, Dr. Srinivas, I'm here. You're able to hear me?
Yeah. Dr. Raghunandan, over to you.
Thank you, Dr. Srinivas and the organizers for giving me an opportunity to talk on this topic on this platform. Can you...
Ishika, can you just help him?
Yes, sir. We will present 1 second.
Yeah. Yeah, so is it visible to all of you?
Yeah, it's visible.
Okay, thank you. So thank you once again, Dr. Srinivas and the organizers for giving me an opportunity to talk on this quite interesting topic, interesting from a surgical perspective as well, because this particular study has a potential for changing the current practice in low rectal cancers. When we look at next slide, please. Yeah, when it comes to rectal cancers, the standard of care, as all of you know, is primary surgical resection. To put it very simplistically in this slide, you can say there are 3 types of cancers, like the good, the bad, and the ugly. The good ones are the early rectal cancers ones, up to clinical tumor stage 3A with no nodes and less than 3 centimeters, a mobile polyp. that will be early stage, the good cancer, so to say. You go on to the next progression towards the bad ones, which are stage T3B, and less than 5 millimeters in the mesorectum, with maybe an N1 and a little more than 3 centimeters or less than 5 centimeters. Whereas the really ugly ones you manage with pre-op neoadjuvant chemoradiotherapy followed by surgery. The ugly ones are the CT3s and T4s with node positivity or the mesorectal fascia being threatened or involved, plus T4 surgeries, T4 tumors involving the adjacent organs as well. So this study particularly concentrated on the early rectal cancers, T2 and T3s up to T3B. They included a novel therapy, which is called a papillon therapy, to give targeted radiation to the tumor, itself. Next slide, please. When it comes to the tumor board or the multidisciplinary meeting, it is guided by protocols and guidelines, and seldom do we take patient considerations into account. There are patients who do not want surgery, primarily because they are quite concerned about the consequences of surgery or the morbidity. And also in rectal surgery, almost always the patient ends up having either a temporary stoma or a permanent one in case of an abdominoperineal resection. So if patients wanted to avoid stoma, there is little choice that we can offer them. Next slide, please. So the background to this study is Professor Sun Mint in UK, Liverpool. He is one of the pioneers of this papillon therapy. Initially in 2014, the Professor Habagama from Brazil published the study where when they looked at patients having external beam radiotherapy, EBRT, for low rectal cancers, they found a complete clinical response, or CCRs, in almost 30 to 40% of the patients. But when they did the study, they subjected all of the patients, even with the clinical response, complete clinical response, to surgery. But subsequently, they studied patients who did not go to surgery, so to say, like they took a wait and watch policy after complete clinical response. So there was a system developed where they wanted to wait and watch. So on that background, what Professor Sun Mint and team developed was the OPERA trial, where they compared the patients with low rectal cancers and stage 2-3, where they gave a boost of contact X-ray brachytherapy, or the papillon therapy, which followed the standard EBRT. And in this particular presentation, which was presented at the ASCO in Jan 23 this year, they reported the final surgical salvage results of this study. Next slide, please. So this was a European phase 3 trial. OPERA stands for organ preservation in early rectal adenocarcinoma. So they divided the patients into 2 arms, arm A being the standard treatment arm with external beam chemoradiotherapy of 45 gray in 25 fractions over 5 weeks with capecitabine, followed by an EBRT boost of 9 gray in 5 fractions for 5 days. This was compared to the arm B, or the experimental arm, where the standard EBRT was followed by this papillon therapy, which is the contact X-ray brachytherapy boost of 90 gray in 3 fractions over 4 weeks. Next slide, please. So the study design, this is the study design. So the arm A, which is in yellow, was the standard treatment arm with capecitabine and EBRT, followed by the EBRT boost. Then in arm B, which had the papillon therapy boost, EBRT was followed by the contact brachytherapy, the Papillon therapy. Within arm B, they subdivided them into B1 and B2 based on the size of the tumor, which was B1 being less than 3 centimeters and B2 being more than 3 centimeters. The inclusion criteria was that all of the tumors should be biopsy-proven rectal adenocarcinomas with a clinical tumor stage of tumor grade of 2 and 3A or B with N1 node positivity, less than 8 millimeter lymph nodes, and no metastasis. So following the radiotherapy, the patients were assessed at week 14, 20, and 24, which was at the end of 6 months. So during this period of follow-up, patients who had a partial response were subjected then to a radical total mesorectal excision. Patients who had a complete response but had a recurrence or had a recurrence, depending on the size, were subject to local excision. And complete clinical response who did not have any recurrence or were put into the wait and watch category. So every 3 months post-surgery, they were subjected to follow-up until about 38 months or so. Next slide, please. So briefly, this slide describes you how the Papillon therapy or the radiation is delivered. Basically, it has an applicator or something like a proctoscope where it is inserted into the patient's rectum and the tumor is completely isolated in the applicator and high radiation is given. It delivers low energy, but very high radiation dose, about 30 gray, that is per fraction. But the volume is low volume directly on the rectal tumor. So basically, at every setting, they provide this therapy. And as you can see in the next subsequent slides, it slowly shaves off the tumor layer by layer until the normal mucosa is reached. Next slide, please. So a schematic representation, and in the top left-hand corner, you see how the patient is positioned in lithotomy. This can also be done in a prone jackknife position. And it requires special equipment, and this is the probe and inserted into the rectum where the radiation is delivered. So schematically representing this tumor, the rectal wall itself is around 5 millimeters or so, and the perirectal fascia then ensues. So the radiation is directly given onto the tumor. The depth of penetration is only up to about 10 millimeters or so. So it completely covers the rectal wall. And even at the depth of 5 millimeters, you have a good 60% radiation strength. And even beyond 10 millimeters, there is about 38 to 40% strength of radiation. This is, of course, very high radiation when compared to other modalities. But because it is in a very small area and small volume, the authors considered that this could be a safe method. Next slide, please. So when it comes to results in terms of EBRT versus contact brachytherapy, as I mentioned, Professor Habagama's paper in 2014, they had given, I think, around 60 gray fractions. And the rate of response or the rate of regrowth in earlier studies were close to around 30%. But Professor Sun Min, which is the Papillon therapy, which we're discussing right now, the regrowth is only around 11%. So that's quite a significant change in the results. Next slide, please. When it came to the dose escalate, this is a figure from the Dutch result. From the previous slide, there was an appellate author. They had done a predictive dose response curve in order to find out what would be the maximum radiation dose that can be given to get a 70% response. So they calculated that at least 92 gray would be required to achieve a 70% response, which is very high when it has to be given by EBRT. However, through Papillon therapy, what Professor Sament has achieved is that he's able to give at least 90 gray to the tumor, and hence being able to give a good response. Next slide, please. So the patients were assessed at 14, 20, and 24 weeks. For patients with a complete clinical response, a wait and watch policy was adopted. And for any recurrence or for patients who partially responded, surgery was offered, either a radical surgery or local excision, depending on the size of the tumor or recurrence. Next slide, please. So here it clearly pictorially represents how the tumor regresses with every session of the contact brachytherapy. So the applicator, as you can see, is around the tumor on the left side. And even after the first fraction, you can see that normal mucosa around the tumor has regressed, and you can see normal mucosa coming around the tumor. And in the third session, almost after the third session, you can hardly see any tumor tissue. Next slide, please. I think you went back, sorry. Yeah, so this was a 5-year study, and 148 patients were enrolled, out of which 141 were evaluable according to the inclusion criteria. The median age was 68, and a high proportion of males were included in the study. So in arm A, which is the standard treatment EBRT, there were 69 patients versus 72 patients in the experimental arm with the contact brachytherapy boost. Next slide, please. So the median follow-up of 38 months, is little over 3 years, and 6 months rate, the complete clinical response rate was 64% in arm A, compared to 92% in arm B, which was quite clinically significant. In arm A, the patients, 46 patients needed surgery, either TME or local excision, whereas only 20 of them in arm B, which is the experimental arm, required surgery. Next slide, please. So the 66 patients who had surgery with the residual tumor or local regrowth, out of which about 60% had a radical surgery, and a local excision was carried out in about 40%. Next slide. So when they looked at the recurrence rate of tumors between arms A and B, you can see there's a significant difference in arm B, with only 19% recurring, and in arm B, almost 40% at the 3-year mark. Next slide. When it comes to the surgical salvage, patients having TME or local excision in each arm, 67% in arm A had surgery, whereas only 33% in arm B had radical excision. So you can see the significant number of patients who have been saved from having a surgery with its inherent morbidity. And when it comes to local excision, 74% of patients in arm A had a local excision, whereas only 26% in arm B. So there are significant findings in this study. Next slide, please. If you recall in the slide in the design study, they had subdivided the arm B into B1 and B2, where the tumor size in B1 was limited to less than 3 centimeters. So when they compared like with like in arm A, that is in patients with less than 3 centimeters in arm A, what they found out that the organ preservation, which is OP, the organ preservation rate in arm A, which was the standard arm with tumors less than 3 centimeters, 63% had organ preserving, whereas when it came to arm B1, which is patients who had the experimental brachytherapy and tumors less than 3 centimeters, 97% with a significant, with clinical significance, had organ preservation. So it is quite impressive, these findings, where nearly all of the patients who had less than 3 centimeter tumor with contact brachytherapy did not have any surgery. A 3-year survival with organ preservation was 57% in arm A versus 79% arm B, which was also significant. Next slide, please. So it's a graphical representation of the previous slide. As I told you, 97% in arm B with contact brachytherapy had a complete, had organ preservation. Next slide. So to conclude, what the authors, the team here have able to show is that in early rectal cancers with the tumors grade of T2 to T3, a boost with a contact brachytherapy gives a very significant advantage and helps patients to and helps to have the surgical salvage reduced and organ preserved, which can reflect or which will reflect in better quality of life in terms of treatment. In patients with less than 3 centimeters, there is a very significant improvement in organ preservation rate when the papillon therapy is applied as a boost to, which is followed by the EBCRT. To summarize, early rectal cancers up to T3, T3B, which are tumors 3 centimeters or less, and subjected to a papillon therapy boost, have the best results of organ preservation. I think that was what the team set out to achieve. Just a couple of comments regarding practicality, and as this was a European trial, just thinking about our own Indian setting in the Indian practice here, I would also welcome any comments from our radiation oncologists in the group, whether something like this is feasible in an Indian setting. Of course, there's the issue of cost. There's a special equipment that is required. And not only that, they would have to have very short follow-ups, like almost every 3 months, either with an MRI or an endoscope or something. So there is patient compliance factors also here. But this is potentially practice changing and a paradigm shift in treatment of early rectal cancers. Thank you. Open to questions. Thank you, Dr. Srinivas.
Raghu, thanks for that excellent presentation. This paper is something very, very important in our clinical practice. When we see the patients coming to the clinic, when we say that you have to go APR, you should have colostomy, even if it is a rectal cancer, a tumor where you don't have a choice, the way they have the emotional trauma in their face is something incredible. True. I think what you have shown, 97% of organ preservation and not affecting the overall survival. In fact, overall survival was much, much higher in the papillon group versus the standard arm. And without affecting the survival, without affecting the recurrence, giving this kind of a organ preservation, something very, very commendable, and hats off to the team. Yeah. The guts, what they had to do this trial. I think we need to congratulate the team the way they have done it. Yes. And secondly, probably the equipment, as you were telling, I think Dr. Vinay, if he is there, I would welcome to join. He's a radiation oncologist at Bharat. Dr. Vinay, are you there? So what they are doing is actually interstitial brachytherapy or something like in our center only, even for esophagus, sometimes they do with the help of endoscopy. They do this kind of a brachytherapy, a local brachytherapy. Yeah. And we are very well versed with cervix. Brachytherapy, that is the standard of care in cervix. It's easy. And as you said, rectum being not very deep, I think it's easy to achieve.
It is very accessible, but we are limited with the anatomy and the pelvis around. Yeah. So I think any tumors less than 12 centimeters should be reachable with that particular instrument, any proctoscope.
Absolutely.
So yeah, this is a welcome paradigm shift in terms of treating low rectal cancers.
Absolutely.
And as a surgeon, I come across patients with low anterior resection. They have something called as almost 30% have low anterior resection syndrome, which kind of affects their quality of life and day-to-day activities. So something like this, if you tell them there's a choice, I'm sure they would gladly accept it.
I think the way forward, a lot of studies are going to come with these. And what we already also realized is radiation becomes so important in the paradigm, in the treatment paradigm of rectal cancers, whether it is middle third or lower third. Radiation takes a higher priority, whether you achieve through EBRT or brachy or local. This is very, very important.
Radiation is playing a very primary role in treatment of rectal cancers, especially.
Absolutely. So once upon a time, it was thought that surgical approach would be the only way
That
to
is the only choice. Yeah.
now, but the things are changing. I think more and more studies are going to come regarding this. Thank you so much for joining us. That was a very excellent presentation. Thank you. Thanks for that.
Thank you.
We have a last topic for the day. Dr. Abhay Kumar, Senior Medical Oncologist at Manipal Hospital, Bangalore. He is going to present 5-year follow-up phase 3 trial, 4 versus 8 course of S1 therapy for patients with stage 2 gastric cancer, and then we will conclude the session. Dr. Abhay?
Yeah, I'm here. So am I audible?
Yes, sir.
You're audible. Your slides are also seen.
Thank you once again, Dr. Srinivas. And I think I'm the last batsman. So this is one of the important abstract presentation, one of the important phase 3 study. So that is 5-year follow-up results of randomized phase 3 trial comparing 4 courses versus 8 courses of S1 adjuvant chemotherapy for pathological stage 2 gastric cancer. So it is JCOZ 1104 study. And so now there's a lot of buzz about S1 since because nowadays many people are using S1 either single agent or with combination of chemotherapy. Some are replacing it to the with the capecitabine, and when cardiotoxic when patients are having cardiac issues, they are using alternative S1 as an alternative compared with the capecitabine. So a lot of indications now people started using S1 since because it is started available in India since last 1 to 2 years, and we know that the standard of adjuvant chemotherapy, what we practice is based upon the classic trial, that is Capox is the standard chemotherapy based upon the classic trial which has been done in China, Taiwan and South Korea. But in Japan, the standard adjuvant chemotherapy is S1, so which is given for 1 year, and where that study has shown that in ACTS-SC, which is a randomized phase 3 trial, patients who underwent gastrectomy with D2 dissection was with S1 adjuvant S1 for 1 year versus only surgery. The S1 arm, the 5-year survival is 71% versus 61%. That is nearly 10% significant survival benefit. So in the phase 3 trial, so the prognosis has, based upon the available of this S1, the prognosis has been increased with the 5-year survival is achieving up to 84%. But the 1 year which has been used in the Japanese trial, it is not based upon any solid evidence. So that's why, so this study is about whether 6 months of S1 whether 8 courses. So only stage 2 gastric cancer have been included in this study. So this study is already, once the interim analysis has been done, so with 528 patients, the study has been terminated early, so due to futility. So where they found that 4 courses of S1 is inferior to the 8 courses of S1. So because the inferiority hazard margin was 2.9, so this study has RFS hazard ratio was 2.54. So hence the study has been terminated, and the follow-up has been continued. So you can see that patient with stage 2 gastric cancer post-surgery has been randomized to 8 courses of S1 versus 4 courses of S1. So the dosage is 80 mg meter square per day, given for 4 weeks with 2 weeks rest. And they are randomized based upon the patient is less than or equal to 69 year or more than 70 year, stage 2A versus 2B, and type of surgery, whether laparoscopic and open surgery with or without birsectomy. And these are the eligibility criteria. Patients with adenocarcinoma with pathological stage 2 are included. Patients with the T3N0, T1, N2 to N3 have been excluded. Good performance status patient. If the patient is having stage 1A, at least they should the minimum surgery criteria required is that gastrectomy with the D1 plus or D2 dissection. If patient is having stage 1B onwards, they must have D2 dissection. And also similarly, if the patient is having one stage 2 disease, then they should have laparotomy surgery. Only stage 1 are allowed laparoscopic surgery, and patient should be randomized within 7 weeks after surgery. Patients with 20 to 80 years have been included, and there should not be any remnant disease after surgery. The primary endpoint was relapse-free survival. Secondary endpoints included overall survival, adverse event, time to treatment failure, and the proportion of treatment continuation. So at each time. So 590 patients have been randomized to equal numbers, 1:1 randomization, 295 patients with 8 courses and others 4 courses. So after the completion of the study period, around 27 patients who have been on 4 courses of S1 have been asked whether they want to continue to receive 8 courses, because since interim analysis, the benefit for the 8 courses has been told to reveal to the patients, so they can opt either to off-label to continue 8 courses or they not opt. So among that, majority around 22 patients have agreed to continue up to 8 courses, and 5 patients didn't agree. So if you see the baseline characteristics, so almost all characteristics are well matched between the both groups, and the majority of the patients are younger patients with median age is around 64 years with good performance status, and most of them are node positive disease with N2 disease. A majority of them having N2 disease, and most of them underwent open non-birsectomy, and majority had D2 lymph node dissection, which is more important, and also most of them have undifferentiated histopathology report. And if you see the result for relapse-free survival, after 8 courses, the 5-year relapse-free survival is 87%, and 4 courses it is 85%, and the hazard ratio is 1.26. But the hazard ratio for to prove non-inferiority was 1.37. So it is found to be inferior. Again, the same for overall survival is also same. The hazard ratio is 1.12. 5-year overall survival is 89 versus 88% in both the groups. So the study has been concluded that so even after the 5-year analysis, 5-year follow-up analysis, the S1 adjuvant chemotherapy for 1 year for stage 2 gastric cancer is highly recommended. So I think I will finish it this. Thank you.
Thanks, Abhay. Thanks for that excellent presentation. So what I am feeling is, if we now Dr. Krishna Prasad presented one adjuvant study about nivolumab. So what we are having post neoadjuvant or post CTRT, post surgery, we have a lot of options now. Whether you can give S1 therapy or you can give nivolumab therapy. What's your opinion? How do you want to choose? Tomorrow you have a patient, gastric cancer patient, locally advanced, but you have given neoadjuvant therapy. Patient has responded well. Patient has done. Patient underwent surgery. Now there is a residual disease, like say T2 N0 disease. So what do you want to do?
So as of now, I'm still continuing FLOT only, adjuvant also.
Okay. So you want to continue chemotherapy, not S1. You will wait for more data, more better data, or
No, S1 data is only where in the adjuvant setting if patient is not receiving any neoadjuvant.
Okay. So the point is, if the patient is undergoing upfront surgery, then adjuvant you want to give S1 rather than EVOX or ECF or FOLFOX or CAPOX.
Yeah, as of now, see, we are using CAPOX based upon the classic trial.
Correct.
And this is also one of the important trials since S1 was not available.
Yes.
So we never explored this option. So now we can explore this option because it is a oral tablet which can be taken at home. So hospital visits can be reduced and more convenient for the patient. And also data is also coming up with S1 docetaxel, S1 cisplatin in the adjuvant setting.
Correct. And as you rightly said, S1 being a oral pill, it's easy. And now a lot of generics are available for S1 in India. Before it was S1 was very expensive. Now many companies are manufacturing S1, Natco, Lointas. Many companies are manufacturing S1. Now it's available in our pharmacy. I think for a very affordable rate. I think patients will be very happy rather than asking them to come once in 2 weeks or once in 3 weeks repeatedly for 6 to 8 cycles. Probably, and as one more thing is COVID times. Now it's not there, of course. It would be very easy to send them with a pill rather than asking them to come repeatedly for hospitalization for chemotherapy. Yeah, I do agree with you. So thanks for that excellent presentation. We have come to the end of the session. Successfully day 2. I thank all the speakers, panelists, and I thank Dr. Dan Edreka from Israel who has delivered an excellent talk. I thank my scientific committee members, Dr. Abhay, Dr. Naveen, Jairam Anvekar, Dr. Raghunandan, for emotionally supporting me in all the aspects to do this conference. And I thank my academic partners, AstraZeneca, Merck, Bayer, Glenmark, Intas, Natco, Roche, and Zydus. Without them, this would not be achieved. With their contribution, it's very helpful to conduct these kind of scientific meetings. And last but not the least, I want to thank the technical team. Excellent job from Ekta ji, Yashika, Gitika, Tarun ji. Thank you so much for such a wonderful coordination. I know that the way they were coordinating, calling all the speakers, providing the slides, all those, it makes so important, and it is so important to coordinate these meetings in a very coordinated way, a smoother way. I thank you so much for all the support you have given. Thank you, guys. And last but not the least, I thank one of my coordinator, Charushila, for making these slides and providing these slides to the speakers, and so that it would be much easier for us to present. I thank one and all. I thank all the participants, attendees, delegates, without which this conference wouldn't be possible. Thank you so much. 1 second.
So
1 second. Hello. Yeah. So I thank the Professor Dan Edreka. I thank Dr. Ravi Tippeswamy for interacting wonderfully with the professor. I thank Dr. Dan Edreka for his excellent talk. Thank you so much, one and all. Good night.
So thank you so much, Dr. Srinivas, for all the opportunity given. And I think we are absolutely on time. On behalf of our entire organizing team, my colleagues, Geetika, Yashika, and Nikta, thank you so much. Stay safe. Have a nice weekend. Enjoy your Sunday. Till that, goodbye till we meet again.
And we
Thank
look forward for many such meetings, Tarunji.
Sure.
We would love to do it. So I got a lot of appreciation. Yesterday, they were saying we will look forward for such scientific meetings more and more.
Sure. Sure. With your guidance, we'll do that, sir. So let's
so
enjoy. Everyone enjoy the dinner. Thank you so much.